right. So next chapter is women's health. Definitely a very important chapter for your SCA exam and for your daily practice as well. So before we go in details or in a bit of more details in each case, we will have the approach for women's health. And believe me, this this approach, that general approach, it will be applicable for many of your women's health cases. So if you understand what you need to ask about, if you remember what you need to ask about, believe me, you should get pass, or I would say even clear pass in your SCA women health cases. As long as you know what you need to ask about, as long as you are making the management in a shared way, especially many cases in women's health, there are many options to offer. Contraceptive options, HRT options, for menorrhagia options, dysmenorrhea, there are many options, and so on. So in the women's health, you will have two cases. Either your patient is a pregnant lady, so you will have some specific questions, or your patient is not pregnant. Whatever the presentation is, coming with asking for contraception, asking for HRT, she's having heavy bleeding, UTI, STI, and so on. So if she's not pregnant, definitely menstrual history is very important. What age did you have your menarche? Is your cycles regular or no? Painful or no? You're bleeding every month, heavy or no? Do you bleed in between your periods or no? And as we mentioned many times, anyone coming with bleeding, you need to ask about anemia symptoms. And is your bleeding is heavy? Are you passing any blood clots or no? How often do you change your pads, and so on? Any family history of any bleeding disorder? Are you bleeding from anywhere else? And so on. And very important in heavy bleeding cases, menorrhagia cases, you need to ask the lady. Super important question. One important question, because that will lead to your management. Are you planning to be pregnant or not? Are you planning to be pregnant or not? Why? Because treating fibroids or treating the heavy periods depends on does she needs contraception or not. Then sexual history definitely is very important. But before the sexual history, because we're still in the menstrual history, there is what we call it premenstrual dysphoric disorder. Usually in the 2 weeks before the bleeding starts, they will come with some mental and physical symptoms like abdominal bloating, breast tenderness, generalized aches, fatigue, and so on, and mood irritability, depression, and so on. So you need to ask about that if your case is about premenstrual dysphoric disorder. Any self-harm, definitely, any suicidal thoughts, and so on. Sexual history as usual. STI, either now or before, and UTI symptoms. And please be careful, any recurrent UTI case in women's. If you have woman, any recurrent UTI case in woman, there are many important questions you need to be aware of. First of all, lady coming with recurrent UTI, you need to ask about STI symptoms. You need to ask about hygiene. You need to ask about sexual relationship and relationship to sex. Is it postcoital UTI or not? You need, if she is postmenopausal, you need to ask about what? You need to ask about topical symptoms. Any dryness down below or no? Very important. Please don't forget this. So in your mind, any recurrent UTI in woman, you need to ask about STI, hygiene, you need to ask about relationship to sex and how many sexual partners. You need to ask about topical symptoms if she's postmenopause. Also, your differentials here mainly will be about cancer and also bowel and the bladder, as we mentioned. So she's coming with bladder symptoms, recurrent UTI. You need to ask about bowel symptoms. Do you know? This only few categories of questions that I told you about recurrent UTI cases in women. If you only ask this, you get clear pass in the history take. Why? Because it is covering differentials, covering red flags, definitely along with eyes and impact and lifestyle. Okay, social history with lifestyle, caffeine, and so on. Then again, very important, because she is a lady, you need to ask about, are you up to date with your smears or not? How was your last smear? Was it normal or not? Contraception cases, very important. Again, in any contraception case, you need to ask about definitely menstrual history, very important. And you need to ask about what? You need to ask about, is she sexually active now, and when was the last sexual activity? Why? Because she may need emergency contraception. And definitely in contraception cases or HRT cases, you need to ask about contraindications. And we'll come to this, but you will find here the contraindications or some of the contraindications like migraine, breast, ovarian, endometrial cancer, DVT, cardiac issues, and so on. Very important. And stroke. Not only this, not only this, also you can ask about in contraception cases, you need to ask about if there is any hirsutism, any acne, your periods are painful or not, heavy or not. Why? Because you know some methods can help with hirsutism or acne and heavy bleeding and also painful periods. Okay, we use combined oral contraceptive pills, for example, if someone coming with polycystic ovary, and they will come with all of that. Then urine incontinence, very important in urine incontinence cases, you need to ask about lifestyle, and you need to ask about how many times she was pregnant before, and mode of delivery. Definitely constipation here is very important as well, because if there is any constipation with incontinence, you need to take constipation as well. Very important. And please don't forget HRT cases. You need to ask about sexual activity. Why? HRT is not a contraception. HRT is not a contraception. And I know some of your colleagues in HRT cases, they forget to ask about sexual activity. If you do that, you are putting your history-taking domain at risk. If your examiner is really strict, this doctor didn't ask about sexual activity, and he assumed she's not sexually active, and he didn't offer safe sex advice and contraceptive advice for her, they may let you fail history taking and as a result management, because this is both this part is linked to management as well. Are you offering contraception as well and safe sex advice or not? All right, definitely impact and the eyes. All of this is, I will not repeat in each case. You need to ask about eyes and impact. Why? Because now you know that it is a must in each case. Then pregnant cases. Pregnant cases, also there are some certain questions you need to ask about. Definitely, is it your first pregnancy or no? Was it planned pregnancy or no? And and if coming with bleeding, you need to ask about definitely how heavy the bleeding is. Is it painful bleeding or just bleeding, just minor spotting without any tummy pain, shoulder tip pain, pelvic pain? And if the bleeding from down below heavy, you need to ask about hemodynamic instability. Do you feel dizzy or no? Lightheaded, palpitations, anemia symptoms, passing blood clots or no? Did you have any miscarriage in the past or no? If yes, how many times and at what age? At what pregnancy age? Okay, and so on. Sometimes you will have pregnant lady coming because of morning sickness. So you need to ask about, if she's tolerating fluid intake, if she's passing urine as usual. You need to rule out dehydration. Do you feel dizzy when you stand up or no? Also, any pregnant lady, you need to ask about, did you contact your midwife? Did you have any scans? Do you take your folic acid and vitamin D, plus or minus aspirin if it is indicated, and so on. If your patient late in the pregnancy, after 20 weeks, you need to ask about headache. You need to ask about any visual change. And if it is later, like third trimester, you need to ask about any itchiness or rash on your body. Did you start also, if she's 20 weeks or 18 weeks and more, did you start feeling your baby movements or no? Are you happy with the baby movements or no? And definitely, in women's health cases, you need to ask about partner. Is he supportive or no? Okay. That is the general approach for women health. Believe me, what we have mentioned now will save time while you are studying the chapter. Why? Because you know that STI cases you need to ask about 1 to 3, HRT 1 to 3, contraception 1 to 3, and so on. So let's start with the HRT. Is a very hot topic for your daily practice and for the SCA exam. So HRT can come in different ways. We'll give you some case scenarios to be aware of. So the easiest one is, doctor, I would like HRT. Or, doctor, I have 1 to 3 as a symptoms and I really struggle. Usually the symptoms will be brain fog, irritability, snappy at work, hot flushes, not sweats, and so on. Their eyes or ideas could be either, yes, I'm going through the change, or I have underactive thyroid. And when you ask why you are thinking it could be underactive thyroid, because my sister or my mom had underactive thyroid before. We always insist, if the patient tells you, doctor, I'm worried about cancer, I think it could be underactive thyroid. You need to ask about why you think that, why you are worried about cancer, why you think it could be stroke, and so on. So try to be curious, try to ask why you think it could be that. You need to get to the bottom of your patient agenda. Or patient can tell you, I think it could be hyperactive thyroid. Also, hot flashes and sweats and so on could be hyperactive thyroid. Another presentation. Doctor, I would like a referral for ADHD assessment. Why you would like a referral for ADHD assessment? I have brain fog. I am not able to focus at work, becoming more forgetful. And usually your patient in HRT cases will be 45 plus. What does that mean? What does it mean? That means if you have a case in your SCA exam for a lady, she's above 45 years old, rule out menopause. Please ask about menopausal symptoms. It can come as a vague symptoms. So, doctor, I would like ADHD referral. Why? As I told you, I have brain fog, poor concentration, becoming more irritable, and so on. And one of my colleagues was diagnosed with ADHD. When you take more history, you will realize that her period is not regular anymore, hot flushes, not sweats. So you would realize that it is likely to be premenopause. She's going through the changes now. What are other also differentials? I would say hypercalcemia. Why? Can give you also like poor concentration, feeling fatigue, brain fog, and so on. All right. So questions to ask, definitely the same approach. You will follow the same approach, but please don't forget vasomotor symptoms here are important, not sweats, hot flushes. What did she try for that? Mental health is important because many of them will have mood irritability, and definitely that will affect their daily function and also work, especially poor concentration, brain fog. Urogenital, in each case of menopause or premenopause, you must ask about any topical dryness down below. Are you sexual active? If you forget to ask again about sexual activity, if this lady is going through the change, you are risking your history taking. Very important. Okay, so ask if she used contraception at the moment or did she use any contraception before, and if she is sexually active now or no. Very important. Some contraindications to HRT, as you can see here. Clotting risk. Did you have any blood clots before in yourself or in your family or in your family? Any history of any stroke, heart problem, high blood pressure? Any personal or family history of breast cancer, ovarian cancer, or womb cancer, and so on. Any history of any liver disease, migraine with aura, any breast lump at the moment. Very important. Any weird or unusual vaginal bleeding. Even it is one of the important AKT questions and concepts. Someone, you are about to start HRT, but she's coming with intermenstrual vaginal bleeding or irregular vaginal bleeding or suspicious vaginal bleeding. What you need to do, you refer her first for the scan and gynae team before you give HRT. That's why you need to rule out any abnormal or weird vaginal bleeding. Why? Because you give HRT, and if she's having endometrial hyperplasia, you are putting her at risk of endometrial cancer, and so on. So, how to explain? Menopause is when your periods stop completely, and usually because your ovaries have stopped producing the female hormone. Female hormones, estrogen and progesterone. Common symptoms, and you take some of her symptoms that she's coming with. Usually ladies will come with symptoms as you described: brain fog, irritability, hot flushes, not sweats, irregular periods, and so on. Although it is normal, but we can explore treatments if those symptoms are affecting your quality of life, affecting your daily function, affecting your work. The HRT helps relieve your menopausal symptoms by replacing the hormones in your body. There are different types. Could be the combined one, or could be the estrogen only hormone. It depends on if you still have your womb or not. But you, in your case, you still have your womb, so you need the combined one. It can come in different forms. Some ladies prefer tablets, others prefer patches, gel, spray. And if the main issue is only topical dryness from down below, discomfort during sex, we can give you only vaginal estrogen. That's why I told you topical symptoms are important. And you need to clarify, is it only topical or systemic or both? And the topical symptoms, dryness down below, discomfort during sex, postcoital bleeding, recurrent UTI, and so on. All of this can be manifestations or signs and symptoms of urogenital symptoms of menopause. All right. Also, HRT it has extra benefit of protecting your bone health. Don't forget it. So here is one of the good cases that it has multiple options. Multiple options. Would you prefer something hormonal or would you prefer something non-hormonal? Hormonal options usually will replace that female hormones. And as I told you, there are tablets form, there are, batch form, there are gel form or spray form. Depends on your preference. Or you would like non-hormonal. Please keep in your mind, what is the first line treatment for vasomotor symptoms in menopause? First line treatment is HRT. Don't tell me SSRI. Don't tell me clonidine. First line treatment to treat vasomotor symptoms in menopause is HRT. If HRT is contraindicated or the patient decline HRT, in that case, you go to non-hormonal option. But you don't start non-hormonal option for vasomotor symptoms unless patient would like and she doesn't want HRT. So if HRT was not suitable, patient declined, contraindicated, in that case you go for the non-hormonal option. But for the SCA, explain we have hormonal, non-hormonal. Usually we start with hormonal option. It is the first option if you don't have any contraindications and you're happy with that. If you don't want, or we feel it is not the best option or not suitable for you based on your history, so we have also non-hormonal options to avoid any unnecessary risks from the hormonal options. If we are giving the hormonal options, we need face-to-face. Why? Because you need to check blood pressure, you need to check BMI and weight. Listen carefully, please. Why? If the patient tells you, doctor, I had already those parameters or those readings done in my gym, it's okay. Please give me the reading. That's fantastic. You don't need to come. Okay? Very important self-help measures. Healthy lifestyle is important. Sleep hygiene, healthy eating, stop smoking, cut down alcohol, exercise, and so on. Also, there is something called menopause-specific CPT, which is very important. And we need to highlight here as well. Some counseling about how you can manage your symptoms by yourself. How can you cope with the menopausal changes? Tips and advice, what you need to do while you are going through the changes. All of this through CPT and counseling. If you want, I can send you the link. You sign up, and it is self-refer. Okay? All right. So, very important. What is the first line treatment option after HRT? After HRT for vasomotor symptoms. It's not SSRI, it's not SNRI, it's not clonidine. It is visolentant. Visolentant, she's taking 45 milligram once daily. And it is, the recent updates in the CKS. Visolentant, how it works? In a very simple way. It works in the temperature regulating center in your brain. It plays up with the chemicals that are responsible for feeling hot, sweaty, having some flushes and so on, hot flushes and so on. So it plays with the chemicals in that temperature regulating center in your brain. It is a basic way how you can explain this. You take it once daily. If she doesn't want this, or she declines this one, at that point you can start SSRI or SNRI. As you can see here, the first line is HRT. If not suitable or decline, what is next for vasomotor? Visolentant. If she doesn't want this, what is next? So that is the third one, SSRI or SNRI. SSRI usually like citalopram or citralline and so on. Vaginal symptoms, definitely vaginal estrogen. Leaflet from Menopause Society, Rockman Menopause, Menopause Matters, all of this. Again, any leaflets, any charity you would like to offer to the patient, I will signpost you to some organizations or charity or website that can give you more information about your condition, treatment options available, when you should seek urgent medical advice, and so on. If you would like more information here, you can see some more information, for example, for hormonal HRT. As we mentioned, if she doesn't have uterus, she doesn't need combined. She will need only estrogen HRT. So she will use estrogen only HRT. If she does have uterus, she needs the combined one. Combined one itself, we have different options. And there is something we call a sequential HRT or continuous combined HRT. So there is sequential combined HRT or continuous combined. Sequential HRT, what happened in sequential HRT? She takes daily estrogen. She takes estrogen every day. However, progesterone, she takes progesterone for 10 to 14 days, either every month or every 3 months, to induce bleeding and to offer some protection to the endometrium. Sequential HRT we give if she is less than 50 years old or she is still in the first 12 months of her menopause. Sequential combined HRT, she will take daily estrogen and progesterone every day. So in sequential combined HRT, there is expected bleeding, but in the combined HRT, there is no expected bleeding. We give combined HRT, continuous combined HRT, if she's more than 50 or more than 12 months from her menopause. And usually, women less than 50, we give sequential HRT, so they will have monthly bleed, or every couple of months they will have, some bleeding down below. So it will mimic the normal hormonal changes in her cycle when she used to have monthly bleed. You will find here many examples. For example, Evril Conti or Evril Sequi patch, if she prefer patch, or tablet from Stone tablet. That is a combined one, and so on. So we'll have here different options, even different, names for vaginal forms, like Plisil vaginal gel. If you would like, if her main issue only is topical vaginal symptoms, so you can give Plisil vaginal gel, okay, and so on. Don't forget, if anyone taking HRT, they need annual monitor, annual review. We review what? We review if she's tolerating the HRT. Usually we follow up after 3 months to make sure they are tolerating it well without any side effects, and they are happy to continue. And then every year, we check blood pressure, we check weight, we make sure that there is no any, breast lump, unexpected vaginal bleeding, and so on. And she's tolerating it well without any complications. And if she's happy to continue, we continue. Again, for your knowledge, you need to be aware of there is no cut-off age or upper age limit for HRT. As long as she is happy to continue, it doesn't matter if she's 60, 70, 80 years old. Usually, we start to win her down and see if symptoms remains well controlled without HRT, so there is no need. But if she prefers to continue in HRT, it's up to her as long as no contraindications and she's tolerating it well. Then here is algorithm about HRT, the same as we mentioned, the same as I mentioned. Everything here will be mentioned to you, and here again visolentant as well, okay, and some basic knowledge for your daily practice. If you want, you can read more information to collect about contraindications, risks, and so on, well written, to the point. I highly recommend try to go through that. All right, so before going to the next case, I wanted to highlight something very important. So as I mentioned earlier, for HRT cases, it can come as a lady coming telling you, doctor, I think I have ADHD. or doctor, I have underactive thyroid, or doctor, do you think I have underactive thyroid? And maybe even the patient will ask you that question at the end. Doctor, do you think I have underactive thyroid or ADHD? Super important when you start your management. As I told you, always start the management by addressing the patient agenda. So acknowledge her concerns or her ideas and her expectation. So start, for example, I know that you think it could be ADHD. However, ADHD, usually you will have symptoms that is consistent in many, many aspects and in different situations, not only at work, in different situations, social interaction. However, from what you have told me, it doesn't sound to be ADHD. However, we'll keep eye on things. If we treat you as if it is, the hormonal changes and you are approaching the menopause, if we treat you for that aspect and it doesn't work, or you still have symptoms, we can reassess you again. But from what you have told me, it doesn't sound to be ADHD. Does that make sense? Then you start your management after that, or next step in the management would be giving her options. So moving forward, so you acknowledge her ideas about could it be ADHD. Actually, from what you have told me, it doesn't sound to be ADHD. ADHD, usually there is hyperactivity, inattention, impulsivity. However, you don't have any of this, and especially your symptoms started to appear recently, not for long time. You don't have symptoms since childhood, because this is very important as well to clarify in the history taking. Onset of the symptom. Is it since your childhood? So we can think really about ADHD. We can consider ADHD, or just started recently. Why? You need to convince her why it is not ADHD. This is important, by the way. Then, if the patient tell you could be underactive thyroid, you need to ask, and you need to be curious why you think it could be underactive thyroid. That's a really good question, because underactive thyroid can have symptoms that sometimes overlap with menopause, like affecting your concentration, making you feel tired most of the time, plus some other symptoms. But if you are worried about underactive thyroid, we can arrange a blood test for you to check your thyroid function test or thyroid gland. All right? So that is very important. Again, whatever the patient agenda, always put it in your mind. Start your management by addressing this agenda. It is Imtiyaz approach since we started SCA, and this approach did help hundreds, honestly hundreds, if not thousands of colleagues to get clear paths in most of the stations in SCA. How you can make it patient-centered, start by addressing the patient agenda first, and then give options. Very important. Next case. Go through that. Then, next case, so we discuss in HRT cases, different case scenarios, different presentations. Someone worried about ADHD, someone think it could be hyperactive or hypoactive thyroid, underactive or hyperactive thyroid, or someone asking for the HRT straight away. The other presentation could be someone you already started on HRT and they are coming with bleeding, or someone they don't take HRT, they are already postmenopause, but they are coming with vaginal bleeding. You know the general rule: postmenopausal vaginal bleeding is endometrial cancer until proven otherwise. So they need to be referred with urgent ultrasound and quick referral as soon as possible. So vaginal bleeding in postmenopausal females can come in different ways, as I told you. But the most common two ways is someone had HRT and then it started to have bleeding, or we changed the dose of HRT, then it started to have bleeding, or postmenopausal vaginal bleeding. Again, same approach if someone coming with bleeding down below. But please, here you need to ask about cancer risk factors, cancer symptoms, and also cancer risk factors. You know, also smoking, alcohol are risk factor for cancers. Not only this, okay? So you need to ask about the smear and if the last smear was normal or not. It could be endometrial cancer, or it could be what? Could be cervical cancer. So you need to make sure last smear was good. Ask about also sexual activity. Okay. Ask about family history of cancer. So the same approach and the same questions, but please, what you shouldn't forget here, last smear, cancer symptoms. Last smear, weight loss, not Swiss lumps or bumps in where, and so on. And lifestyle as well. Okay. And if she was started on HRT, you need to ask, for how long did you take HRT? Did you miss any day or not? Did you miss any day for the HRT or not? Any recent change in the dose or not? Those are the important questions depending on the case scenario. So how to explain? You need to explain that it's quite common to have some bleeding after you start HRT because still your hormones are not stable. And your body try to adjust to your hormonal changes, including your womb lining. However, there is risk assessment. We need to check if you are at risk of having womb cancer or not. If you have any risk factors, we need to arrange jelly scan of your womb as soon as possible to rule out any possibility of womb cancer. That's why it doesn't matter if she started her HRT recently or not. Even if we started HRT last week and we expect she may have some irregular bleeding, if she came with bleeding, we need to risk stratify her. Does she have any risk factor? Because if she has one major risk factor or three minor risk factor, straight away, ultrasound scan. Or two minor risk factor, again, ultrasound scan urgent within 6 weeks. And we'll come to this in the algorithm for British Menopause Society. Very nice algorithm, very well written. We need to be aware of that. All right, so we need to assess, because if she's having any risks, we need to rule out any womb cancer. Okay, and the good news is in most of the cases there is no womb cancer, but it's just as a precaution to be safe rather than sorry. So if you suspect cancer, try to be very sensitive but optimistic. I'm afraid I don't have a good news for you today. From what you have told me, I'm concerned it could be something else, like cancer. I'm not telling you it is cancer yet, and it is just as a precaution. We don't need to miss it. Any lady coming with bleeding after menopause, we need to assume it is cancer until proven otherwise. However, the reassuring part is many ladies in your situation, it turns to be not cancer at the end. Okay, again, try to be sensitive, but again, try to be reassuring because there is nothing confirmed 100%. What we are doing is we are ruling out cancer. Again, the idea of 2-week referral in your primary care, you are not diagnosing cancer. You are ruling out cancer. You know, if everyone you refer as 2-week referral turns to be cancer, that means you are missing non-cancer patients quite a lot. And you are missing cancer patients quite a lot. The idea of 2-week referral, you are referring to rule out cancer. So you will not miss cancer patient. Okay. If HRT related, we need to assess if she has risk factors or not. For example, being obese is a risk factor. Having diabetes is a risk factor for cancer. Okay. That's why there is, you would even find that there are minor risk factors, as you can see here, and major risk factors. BMI, it depends on. If someone has BMI 40 or more, it is major risk factor. What does that mean? That means if you started here on HRT last week and she's coming with bleeding today, you assume it might be cancer. What you need to do, as you can see here, urgent suspicion of cancer pathway. You need to refer her to have ultrasound scan within 2 weeks to rule out endometrial hyperplasia and to assess endometrial sickness, and so on. So one major or three minor risk factors, yes. Urgent. Okay. If two minor risk factor, she will need urgent ultrasound within 6 weeks. This one within 2 weeks. Okay. Face to face, definitely. She's coming with bleeding. You need to offer face to face. Why? Examine the tummy, and maybe you can also examine the vagina from down below with chaperone. Blood, very important, including for blood count and the blood clot, kidney function, and LFTs. And most of the ladies you will refer as urgent ultrasound scan, either within 2 weeks or within 6 weeks. Then leaflets and safety net if bleeding gets worse. severe pain, feels unwell, anemia symptoms, come back, and follow up after the ultrasound scan results and blood test results. And here is the British Menopause Society. So if someone coming with unscheduled bleeding while they are taking HRT, definitely assess the cancer risk factors, either minor or major. And definitely you need to identify what kind of HRT. Compliance, did she miss any day or not? Okay, and then examine her and offer investigations. If there is any swabs to be taken, if you suspect it could be STI, STI can come with also bleeding from down below or intermenstrual bleeding. Cervical screening, if she missed her cervical screening. So if one major risk factor, and here there are the major risk factors here, you need to go through them. So urgent ultrasound within 2 weeks for suspected cancer. And then depending on the ultrasound scan results, if the endometrial thickness, if she's taking sequential HRT, came back more than 7, you need to refer for urgent suspected cancer pathway as 2-week referral. Or if she's taking combined continuous HRT, and endometrial thickness is more than 4, she needs again urgent 2-week referral. If she is having heavy persistent bleeding, she doesn't have 1 major or 3 minor, but she have heavy or persistent bleeding or 2 minor risk factors, or more than 6 months since we started HRT, or more than 3 months since we changed her dose. If yes of this, she needs urgent ultrasound scan within 6 weeks. And if the ultrasound scan came back suspicious like this, we need to refer her as urgent cancer pathway, and so on. If no, so there is no any 1 major, 3 minor, and there is no anything of this, we need to optimize the HRT for 6 months. So either we increase the progesterone dose or reduce the estrogen dose, and then reassess the bleeding, okay? Then you can read here some information for you as well about sequential and continuous combined, by explaining to you what is the difference between them. Then HRT review. I give you a very important fact. The fact is, there is no upper age limit for the HRT. So let's say, and listen carefully to the case scenario, you have a new patient registered to your practice. So you don't have the full records for her. And this patient called a few days ago to request re-prescription of her HRT. She's already on HRT. She's about to run out, and she's requesting more HRT. She's how old she is? She's 60 plus years old. 60 plus years old. So the nurse booked her to see you. Why? Because newly registered, she's requesting HRT, and she's more than 60 years old. We don't know what is going on. So she's coming for HRT review. So important questions you need to ask here. For how long do you take HRT? What is the age of your menopause? You need to ask about any breast cancer symptoms. You need to ask about any womb cancer symptoms. Bleeding from down below. You need to ask about side effects from HRT, any breast tenderness, any headache, any skin irritation from the topical or local or transdermal HRT. This lady, she's not on oral. She's taking the patches, the transdermal one. By the way, don't confuse yourself between topical HRT and the transdermal HRT. Topical HRT is the vaginal one. Transdermal HRT is a systemic one. Transdermal HRT, spray, gel, or patch, is systemic one. But when we say topical, we mean vagina. When we say transdermal, it is a systemic one. So systemic pathway for HRT, either oral or spray or patch or gel over the skin. The only topical that we mean only vaginal, it is topical HRT like Placil gel, for example. Okay. All right. Then ask if she did try to stop taking HRT and to assess her symptoms or no. If she is open to try to stop HRT or no. Or if she keen to continue on HRT. If she's up to date with her smear, if she's up to date with her breast screen. And ask what matters most for you today. Okay? Because if she would like, to have better quality of life without symptoms of menopause, okay, and she's aware of the risks of HRT, she's aware that it can increase the risk of breast cancer or endometrial cancer, blood clots, and so on. She's aware of the risks, but what is important for her is the quality of life. So she's aware, we continue. Definitely, sexual history is also important. So here, again, how to explain, as I told you, there is no upper age limit. As long as you are happy, as long as you are tolerating it well, you are aware of the risks, yes, we can continue HRT. But what we need to do, because you are newly registered to us, and we are prescribing it again for you, or we are continuing HRT, because we are continuing, not prescribing again, because she didn't stop it. She's still taking it. So we need to see you face to face. I can book another appointment with the nurse to check your blood pressure, your body weight, your BMI, and so on. If everything comes back reassuring or coming back reassuring, so yes, we can reissue your patches to you. At any point, if you change your mind or if you would like to stop HRT, let us know so we can uh, stop HRT and reassess your symptoms and so on. So we will do annual review. The annual review, as I told you, you go through the questions I told you to ask, and then if she's aware of the risk, if she's happy to continue, then appointment can be with the nurse to check her blood pressure, BMI, height, and so on. Make sure she's up to date with her breast screening, okay? And we can put on repeat prescription for her. And advise to attend the annual review. Safety net against breast cancer, endometrial cancer, okay? That's it for annual HRT review. Then low libido after menopause. I have seen this before, probably a few times over the last couple of years or 3, 4 years. Lady coming after menopause and she's having low libido, low desire in sexual activity. So it can have different causes. That's why you need to rule out those different causes. Could be relationship stress. Could be actually topical vaginal symptoms, like there is some, discomfort during sex, painful intercourse. That's why they lost interest because of the physical symptoms related to the sexual intercourse. Could be hormonal changes, which is very expected because after menopause, not only estrogen is low, estrogen and testosterone will be low. Could be chronic issues, thyroid issues, diabetes, and so on. And could be medication induced. SSRIs, for example, can reduce libido. That's why you need to rule out all of that. Or I will not say all because you don't have time definitely to ask everything, but most of that. Okay, and ask if she tried something or no, and ask definitely about sexual history, ask about other menopausal symptoms, and if she tried anything for her menopause or not. And also, was it gradual or sudden? Because if it is gradual, could be because of the hormonal changes, but if it is sudden, maybe some relationship stress, depression, and so on. Okay, so impact definitely on, as I told you, on her mood, on her relationship, and so on. So how to explain low libido after menopause is common due to hormonal changes, especially the drop in estrogen and testosterone, not only estrogen, which can affect your sexual desire and comfort. Other factors like stress, relationship issues, underlying health conditions can play a role, but less likely in your case because you don't have any of this. It's very important to explore both physical and emotional aspects to identify the cause. And while it can feel frustrating, there are effective ways. Again, the good news is there are effective ways to treat it and support you to feel better and to improve your symptoms and to improve your sexual desire. Don't forget, even I told you here, very important about impact on mental health and relationship. Why? Because if there is any impact on mental health or relationship, CBT and psychosexual counseling is important here. And if you suspect any underlying organic cause, face to face. If you suspect thyroid dysfunction, face to face to check signs and symptoms of thyroid disorder. Blood, again, according to what you suspect. But if you couldn't suspect anything, there is no need for blood test. Lifestyle, it changes, is very important. What patient can do, things that patient can do, regular exercise, good diet, good sleep hygiene, and so on. Medications, review. If she's taking SSRI, what about if we can stop SSRI or SNRI? Sometimes can help. If there is any topical vaginal symptoms, topical estrogen gel. As I told you, CBT self-talking, relationship counseling, leaflets, and so on. What if the patient asking for testosterone? You need to explain that yes, I would agree with you. Testosterone could be one of the options. However, we usually don't start testosterone. And if we consider testosterone, it should be under secondary care, not under primary care. And if you start on testosterone, there are, you know, a regular monitor requirement to make sure there is no any side effects, like for blood count, for example, it can cause polycythemia and so on. Okay. So, and sometimes even, changing the HRT from the oral form to transdermal form can increase the endogenous level of testosterone. So it is also one of the options. It is also one of the options. So sometimes changing the HRT, if she was on HRT, coming with low libido, okay, definitely you need to rule out medication induced SSRI, SNRI. No SSRI, SNRI. Rule out mental health issues and stress and relationship stress. Then and thyroid disorder. And then what you can offer, definitely lifestyle advice. And then advice here, what about if we can change the HRT from the oral to transdermal? Sometimes it can increase the level of the inner testosterone that your body making it normally. Sometimes can, because the way that the oral form can affect the metabolism and the level of your inner testosterone, that's why transdermal sometimes can be an alternative option. Why? Because it will make your inner testosterone level more in your blood, and that can improve. If not, so we can refer you to have testosterone under secondary care if they think it is the right option for you, and so on. Okay. Again, some information about testosterone if you would like to read. Breast cancer and HRT. Breast cancer and HRT is good case. And you may think it is complicated, however, it's very easy. It's very easy. And you don't need to ask about all the indications for genetic referral and for, breast clinic referral. But I will tell you what is very important, and I assume that you already asked this in your daily practice, because this is the most common question you need to ask. So I'll tell you the case scenario, so you'll be aware what we are talking about. You have a lady, she's taking HRT, and she's taking estrogen-only HRT. Why? She had her womb removed before, whatever the reason was. She's 50 plus, let's say 53, 54 years old. Her sister diagnosed recently with a breast cancer. And your patient coming to you, doctor, I'm worried about breast cancer. My sister just diagnosed with breast cancer. Could you refer me to breast clinic, please, or genetic test? Should I stop my HRT or not? Not only this, your patient last mammogram was 1 or 2 years ago. It was reassuring. It was reassuring. So this case, it might be tricky in terms of, because you need to ask about menopausal symptoms, you need to ask about breast cancer symptoms, and you need to ask about her sister. So there are many things you need to ask about here. And you need to ask about if there is any other family member affected or not. And any males in your family who was diagnosed or who were diagnosed with breast cancer. So asking about why she's worried about breast cancer, asking about, because it's not only breast cancer, could be bowel, ovarian cancer, and endometrial cancer as well. Ask about cancer symptoms. Ask about menopausal symptoms, and is it well controlled with her estrogen-only HRT or not. This lady definitely, because she removed her womb, you didn't need to ask about endometrial cancer here. But if she didn't remove her womb, you need to ask about endometrial cancer. And ask about for how long she's taking HRT, if any blood clots, and so on. Then, important questions to ask, what age your sister diagnosed with breast cancer? At what age? Because if it was more than 40, it's really good. If it was less than 40, yes, we can refer you to to genetic clinic or breast clinic. And then, do you know if your sister's breast cancer was linked to an inherited gene change? Very important question here. Let's highlight it. Do you know or are you aware if your sister's breast cancer was linked to an inherited gene change? Sometimes we call it, or something we call it, BRCA1 or BRCA2 gene change. And not only this, please, and please, and please. Social history in this case is very important, and right beside social history here is very important. And why social history here is very important, especially alcohol, smoking, and exercise. You know that alcohol can be more risky, more risky for breast cancer comparing to HRT, along with smoking as well. And also exercise has a protective effect against breast cancer. And you can bring this topic to the patient. I can see you are really worried about breast cancer, which is a valid concern. But there are many things that you can do by yourself to minimize the risk of developing or having breast cancer. Reducing or cutting down alcohol, stop smoking, being more physically active. Those are well-known factors that are linked to breast cancer. Okay, so how to explain? Thank you for sharing your worries with me today. I can understand how concerning it must be for you after you hear that your sister just diagnosed with breast cancer. With one affected sister and no other family history, your risk is only slightly above the average. Genetic clinic referral is usually unnecessary unless she was diagnosed at age of less than 40 years old. So unless she was less than 40 years old at time of the diagnosis, or there are additional affected relatives, or she has inherited type of breast cancer. If she does have any of this, yes, I agree with you. We can refer you to genetic clinic or breast clinic. Estrogen-only HRT has little or no proven increase in the overall breast cancer risk comparing to the combined HRT. You are doing amazing job by going for your mammogram. Keep your 3-yearly mammogram and be breast aware. If you notice any breast lump, please seek urgent medical advice. Regarding HRT, it's up to you. If you feel it is controlling your menopausal symptoms and it is giving you a better quality of life, you're happy to continue, you can continue on that. But if your sister told you that it was linked to inherited gene, I would agree with you. We should refer you straight away to the genetic clinic. Okay, so options here, it depends on the answers that she will give you in terms of her sister background and if any other family member, if any males affected with breast cancer in her family or not. And if she's happy to continue estrogen-only HRT, if benefits more than the risks, she can. If she doesn't want HRT, offer non-HRT options, like we just mentioned about visolentant or other options. Attend your usual mammogram. And if you notice any new breast changes, not only lump, skinny changes even, seek urgent medical advice. And how to lower your breast cancer risks, this is important. It's not only about HRT. Many things that you can do to minimize the risk of having breast cancer. Healthy weight, like weight loss can have a protective effect. Reduce alcohol to the recommended level, or even cut down alcohol more. Stay active and don't smoke. See, all of these factors are important when we talk about minimizing the risks of breast cancer. Okay, and in terms, if she will continue HRT, we can use the lowest effective dose. Okay, here are some questions. Go through the questions and answers. If the patient will ask you what question, any question of this, what kind of answer you will give, and also genetic or breast clinical referral, it depends on the answers. Don't forget also one important question you need to ask, and just write it down if it is not there. Ask about any axillary lump. Here it is also mentioned, any axillary lump. Why? Because if the lady coming with unexplained axillary lump, okay, we need to refer her. Okay. All right. That is for breast cancer and HRT. Contraception cases. Again, I like these cases because they are full of options. Very important. Even I written for you here with a bigger size and different color. Your key for the method of contraception is, does your patient need or want or prefer short-term or long-term option? Short-term or long-term option. Contraception here can come in different ways. Minor asking for contraception, or premenopause asking for contraception, or contraception after delivery, or emergency contraception, or missed pill, and she's coming asking for what she needs to do. And will come all of that case scenarios, like missed, for example, a pill, what you need to do, or emergency contraception, what you need to do. So lady coming or minor coming with a contraceptive advice, asking for contraception. Or the other presentation, mom coming for contraceptive advice or contraception, asking for contraception for her girl. And her girl or her daughter, she's having learning disability or Down syndrome. We'll come to this also case scenario. What you need to do. Because there is important question in this specific case to rule out safeguard. Very important here. It's not safeguard, but we'll come to this. So for the contraception, same approach. Okay? Same approach as before. And if she would like something for short term or something for long term, would she prefer something daily? Would she prefer something that she can fit in and leave it for months or even few years time? Definitely asking about the contraindication like migraine with aura, DVT history, any breast lump, and so on, breast cancer, and so on, and any family history of DVT. Asking about sexual activity, if she is already sexually active or no. She may need emergency contraception before the long-term contraception. Any STI symptoms, safe sex, very important. Do you use condoms or no? If she is minor, definitely asking about the partner. What is his age? Are you happy with your relationship? Is he pushing you to have sex with him? Do you feel he's over controlling or controlling you or no? Did you tell your mom or no? If no, why you didn't tell your mom? Any chance you can tell her. I'm not pushing you to tell her, but always recommend it, or we always advise to tell your mom because she can offer you support, advice about safe sex, and she always can support you during your relationship journey, and so on. Okay. Very important also to ask if she had tried any contraception before or no, and if yes, did she tolerate it well? Why did she stop it, and so on. So the contraception, how to explain, actually very natural way. Well, thank you for coming in today. So in terms of contraception, the choice, it depends on you. So we have the long term, we have short term, we have daily methods, we have a method that you can fit and leave it for some time. Do you have any preference, or shall I talk through all options and at the end you can decide? If we run out of time today, we'll give you some information, some leaflets to read about, and then we can meet after a few days once you read once you read all of this, and we can make a choice together or a decision together. All right. So definitely you offer the contraception, it depends on her. Then don't forget, if she will opt in for that and she will use the contraception, we need to check her body weight, we need to check her blood pressure, and so on before that. Then you give her leaflets and then follow up after a few days to see what did she decide, and also if she will start today on contraception, follow up to see after a couple of weeks to see if she's tolerating it well or not, no side effects, and so on. And safety net about migraine with aura, safety net against the breast mass, breast lump, DVT, and so on. Don't forget, again, super important. And if you forget this, you may not get clear path in the management. Don't forget to advise contraception will not protect you against STI. That means you need to be careful, practice safe sex, use condoms to avoid having STI. Also, usually we like to give young girls LARC, long-acting reversible contraceptive. The best LARC for them is implants, not the injection itself. Okay, so very important. So the best LARC to offer young girls is implant, not injections. Why? Injections can affect the bone mineral density. That's why implant is the best option. But again, is not the best option. That means we cannot use injections. It depends on her preference. As long as you explain, it's up to her. Okay. Emergency contraception. Emergency contraception, you need to be very clear. You need to explain emergency contraception reduce, but doesn't fully eliminate the risk of pregnancy. Again, you need to be very clear to this point and around this point. Then, emergency contraception. Very important to ask about when was the last unprotected sexual intercourse? When was your last period? Okay, very important. You need to ask about her BMI. Why? Because if you are giving levonorgestrel, it depends on her BMI, the dose. You need to ask about STI symptoms. You need to ask about, did you do any pregnancy test now? Any chance you can be pregnant or you may be pregnant now? And you can ask, would you like something to be used on the long term or not? Would you like something to be used on the long term or not? Like a long term contraception. And if she was a minor coming asking for emergency contraception, you need to ask about also partner. Was it consensual sex or no? Do you know the partner or no? Also, very good. By the way, it is very good to ask this question in anyone asking for contraception. Because if they have malabsorption, it can affect the oral route. That means you go to other options like implant or injection. So do you have any ongoing diarrhea? Okay, because if she has malabsorption, maybe oral option is not the best for her. So we can give injections or implant or IUD or IRS. All right. So as I told you, emergency contraception, make sure she's aware it reduces the risk, but it doesn't fully eliminate, you know, the chance of being pregnant. So we have three options here. Very important to be aware of the following. The hormonal option, which is levonorgestrel or ELA1, how it works by inhibition of ovulation. It suppresses ovulation. What does that mean? That means if your patient already had her ovulation, less likely it will work. In that case, the only option available is IUD. And IUD, the good thing about IUD, it can be used within 5 days of ovulation or within 5 days of unprotected sex. Unprotected sex. It has a spermicidal effect. It doesn't work by inhibition of ovulation. A spermicidal effect. And also can affect implantation. Okay? So if she had already her ovulation, that's why I need to ask when is your last menstrual period. That is very important question here because you need to be aware if she is halfway in her cycle, midway in her cycle, so her ovulation likely happened already. So less likely hormonal tablets will work, or she's still before her ovulation, so hormonal tablets are likely to work. And definitely when was her last sexual intercourse. ELA1 can be used within 5 days of unprotected sex, and levonorgestrel can be used within 3 days of unprotected sex. ELA1, okay, caution if your patient has asthma. We still can give, but we just need to advise the patient if you know if they have asthma and they're taking ELA1, make sure to monitor your chest symptoms. If you started to have wheezy chest, shortness of breath, please seek urgent medical advice. Levonorgestrel, it depends on her body weight, because if she's more than 70 kilograms, we give double the dose. Okay. What else? ELA1, if she's breastfeeding and she had one time ELA1, she can use, or she can continue breastfeeding. She can continue breastfeeding after single use. If we give ELA1 and she is happy to take long-term contraception, it needs to be after 5 days from taking ELA1. okay? Because they can counteract the effect of each other. So if she's taking Ella1 today, and she is happy to continue or take later on the long-term contraception, the hormonal one, it will be after 5 days from taking Ella1. What happened if your patient already had her ovulation? Explain that. Less likely the tablet will work. So the only option available if you don't want pregnancy is to go for IUD. But I'm very aware that IUD, you may not be able to have it fitted today. We can give you the tablet just in case. Taking something better than nothing, but less likely the tablet will work until you will have IUD fitted in. And the best thing that you can go to family planning clinic to have it as soon as possible, the IUD. Okay? Very important. You can give her leaflets, and very important to advise pregnancy test. Pregnancy test. So if your next period is delayed by more than 7 days, please do a pregnancy test. Or if there is unusual or abnormal bleeding after taking the emergency contraception, please do a pregnancy test. Or if your period occurs within 3 weeks of taking if no period occurs, if you don't have any period after 3 weeks from taking emergency contraception, again, do a pregnancy test. So all of this are very important to tell her that when she should do a pregnancy test. No period happen within 3 weeks of taking the emergency contraception, or if her next period delayed by more than 7 days, or there is unusual or abnormal bleeding after taking the emergency contraception. And here, this is just about, the different options, how it works, and so on. But I told you about all of this already. Missed pill. Patient, she forget to take her pill, and she didn't take her tablets, contraceptive tablets, and she's coming because she missed it. Definitely, you need to ask about how many tablets, how often does she miss the tablets, if she did have unprotected sexual intercourse recently or after she missed her tablet. If she's open to have long-term method or not. Okay, very important. So those are the questions you need to ask. So how to explain missing? Definitely the tablet can reduce the way it works, can reduce the effectiveness in avoiding pregnancy, especially if it happens often or during certain times of the cycle. The next step depends on how many pills you have missed and when in your cycle. Okay, so this is very important. So management depending on what kind of pills. Is it combined tablets or the progesterone only tablet? It depends on, especially for the combined tablet, if it is more than 2 tablets, which week of your cycle, first, second, or third week. If she doesn't want to change her tablet and she's happy to continue with the daily method, there are also very important tips and advice to give her how to minimize the chances of missing your pills. For example, setting reminders, use your phone alarms, applications, calendar notification to remind you to take your tablet on time. Keep your tablets in a very visible place. So it will be, you will not forget. You always see your tablet, especially if you combine it with some routine as well. Take your pill at the same time every day while you are doing daily routine, like brushing your teeth, watching your favorite TV series, and so on. You can consider alternative methods if she's happy. If she's not, at least set up reminder, keep them visible, and combine it with a daily routine. Okay? And always carry a spare pack with you if you are traveling abroad or in case of emergencies. So here is the missed bill rules. We try to make it very easy and very simple for you. And I hope this algorithm will make it very easy for you. So if she's taking the combined tablets, and if she missed only 1 tablet, this is the easiest rule. Take the last missed tablet as soon as you remember, even if you take 2 tablets on the same day. And then continue as usual, no any extra precautions or contraception needed. But the issue, if she missed 2 or more tablets, in that case, she needs to take the last tablet only that the last missed tablet. For example, if she missed 3 or 4, take yesterday one. Today, for example, if she used to take it 9 p.m. in the evening, and now it is 9 a.m. and she missed the last 3-4 days, what she needs to take? She needs to take yesterday tablet, and today as well at night she will take her 9 p.m. So she will take 2 tablets on the same day. And then She needs to continue her pack, and she needs to use condoms or avoid sex for 7 days until she will keep taking her tablets for 7 consecutive days. Then, depending on when in her cycle she forget those 2 or more tablets. If it is in week 1, she consider, and we need to give emergency contraception if she had unprotected sex in that tablet-free week or pill-free interval or pill-free week. If she missed it in week 2, no emergency contraception. If she had week 1, 7 days back-to-back tablets. If she was taking her tablets back-to-back in the first week. And if she missed those 2 or more tablets in the last week or third week of the cycle, third week, she doesn't need to take pill-free interval. She needs to continue back-to-back. So on day 21, she needs to start as a new pack without any gap. For progesterone-only pills, it is simpler. First, it depends on what kind of hormonal tablet, the progesterone-only tablet. What kind of progesterone-only tablets? Is it the traditional one? Okay. Like norgesterone. So we consider it is missed if she missed it more than 3 hours. So she used to take it 9 a.m. Now it is 1 p.m. After 4 hours, it is missed. Or it is second generation, like digosteril, like Cerazid. We consider missed if she forget to take it for more than 12 hours. She used it 9 a.m. every day. She takes 9 a.m. every day. Now it is 10 p.m. It is 13 hours. It is missed tablet. There is a newer version like drospirenol, like Slenda. Slenda, the missed rule is 24 hours. If she's taking 9 a.m. and she missed it yesterday, and now it is 10 a.m. The following day, it is missed. So what she needs to take 1 pill as soon as possible and take the next pill as usual and continue as normal, but she needs to take extra precaution for 2 days, no sex or use condoms until she is taking at least the progesterone-only tablet for 2 days. But for Slenda, she needs to take it for 7 days to be effective. Okay, this is a missed pill rule. Again, some information if you fancy to read about, again, to the point, also about lactational amenorrhea method for after delivery or post-delivery. One of the methods, if she is fully breastfeeding and she's amenorrhea and in the first 6 months, and so on. So some information you can read to the point. Migraine and combined oral contraceptive pills. Very good case about negotiation. How you will negotiate with the patient about this. So it is very important and very good, actually. And I like this case. I don't know why, but I like negotiating case with the patient. So very good to practice on this case. All right. So migraine and combined oral contraceptive pills. I will tell you the case scenario so you will be aware what we are talking about. What we are having here. Lady who is taking combined oral contraceptive pills and she doesn't take it back to back. What she does, she takes it 3 weeks on, 3 weeks she takes it, and then she takes 1 week off. The problem is during this week, when she doesn't take the tablet, she starts to have very, very bad migraine without aura, because you need to ask about aura. And if you forget to ask about aura in this case, you will fail the station. So, lady taking combined oral contraceptive pills, she is having migraine in the pill-free interval or the pill-free week. 1 week, when she doesn't take the tablet, she has migraine without aura, affecting her function. She can't continue work, and she needs every month during that week to take time off work. This lady, she doesn't, and she is insisting she will continue on combined pills. By the way, I have this before. I will never forget 3 times. Why? Because it was hard negotiation with 2 of them. 3 times I had very similar cases in the daily practice. And as I told you, this course is based on common daily practice cases that you see as a GP. And what is common is common. So she doesn't want to change combined oral tablets. She's happy with that. You offer alternatives, you offer non-hormonal, you offer progesterone only tablets. No, she doesn't want. She insists on combined tablets. So what questions you need to ask? Definitely you need to ask about, is it aura or no? Any triggers or no? Is it one side or no? Or both sides? Any red flags? Could be brain tumor, meningitis, fever, and so on. Very important, as I told you, to ask about what did you try for it? Did you take any painkillers? Did it work for you or no, the painkillers? How often do you use the painkillers? We don't need you to have medication overuse headache. It's a different type of headache, sometimes hard to control and hard to treat. So how often do you take your painkillers? Also rule out brain bleeding. And very important to ask about smoking. Stroke history, DVT. And if she is open to try any different contraceptive option for her. And if not, ask why. Impact and social history definitely is very important. Very good negotiation station. Definitely in how to explain and how to approach what you need to do. Acknowledge the impact of her migraine or on her symptoms. And thank her that, yes, I can imagine where are your concerns and where is coming from, especially affecting your work. You have to take some time off work and so on. The good news is there are many options to help you with. So the best option here is to stop your combined tablets and switch it to something else, because we don't like to give combined tablets if someone has migraine, because it can increase the risk of strokes and blood clots. Is not absolute contraindication in your case because you don't have aura, but we prefer not to give for a long time. Does that make sense? Are you happy to try different options? If not, okay. So options for you now, if you would like and if you insist to continue on your combined tablets. Option number one, instead of taking 3 weeks and leave it for 1 week, take 1 week off, take it back to back. Why? Because it looks like your migraine happening in this week off, that pill-free week, because of the hormonal changes and the drop in your female hormone level. That is the main cause. Because I cannot see any other triggers from your history. So what about if you take it back to back without any pill-free interval? And you can take it back to back for 3 months, 4 months, 5 months, or back to back, and then for some time, and then take 3-4 days off where or when you will have some bleeding. What do you feel about that option? Or continue taking as it is, 3 weeks on, 1 week off, but we can give you a daily tablet. We call it a prophylaxis. For example, beta blocker, propranolol, or amitriptyline, to reduce the frequency and severity of your migraine. Or we can give you a sumatriptan to take when you will have your migraine attack. Stronger version, or a stronger tablet or stronger painkiller that can help with your migraine anti. If that help during your migraine days, very good. If it doesn't help, so we can review other options together as well. See how many options in this case, and see this is the way how you can run an SCA consultation, offering options. That's why, by the way, Woman Health chapter is my favorite chapter among all SCA cases and all SCA curriculum, and even during daily practice. Why? Too many options, and you put all those options on the table for your patient and let her choose. And document you discussed all of this, patient aware of the risks, happy with the that, and involve her in your decision. Okay. So this is the management, by the way, and let her choose whatever she wants. Either continue and give it somatriptan and or there is also many prophylaxis, by the way. Take zolmitriptan or fruvatriptan around menstrual week or around the bleeding week when it is expected for her to have migraine, because she will stop her tablet. For example, if it is 28-day cycle, she will stop her tablet on 21 day, and then she will have that bleeding during this week. So she can take it just before she finish her estrogen tablet or the hormonal tablet, I mean the combined tablet, the mini prophylaxis. She can take it when it is expected to have migraine, brovatriptan or zolmitriptan, or she can take somatriptan, the tablet, on the days when she has migraine as an acute treatment, or daily prophylactic tablet, amitriptyline or propranolol, or she takes it back to back. And definitely the best option, switch it to non-combined tablet. But again, it's up to her. And definitely safety net here, it will be safety net against migraine with or stroke or DVT. And follow up after a few weeks to check how effective is that option that she choose in reducing the frequency of having migraine. You may offer definitely sick note, but if she tell you I'm struggling with work, but plus or minus. Also migraine or headache diary, if we don't know what is the trigger, but if she tells you clearly there is no any triggers, and it is only around that week when I stop my tablet and I have bleeding during that week, so likely to be the hormonal changes is the main trigger for her migraine. Next, amenorrhea while on progesterone only pill. Let's say you are having 46, 47 years old female patient. She used to take combined oral tablet. She used to take the combined tablet. And because of her age, one of the advanced nurse practitioner, one of the advanced one of the other colleague, your colleague, GP colleague, or advanced nurse practitioner, they stopped her combined tablets and they started her on progesterone only pills over the last few months, 3-4 months. The patient, since she was started on progesterone only pills, she doesn't have period. That's why she's coming, doctor, I don't have any period. I think something wrong happening with my body. Eyes, listen carefully, because you need to be flexible. Even, in your day, same patient, same role player can tell you one eyes and add totally different eyes to your colleague in the same setting, in the same day, in the same circle. You need to be flexible. So sometimes eyes for this case, nothing. Sometimes eyes, is it because of my tablet or is it because of my menopause or I'm now menopause? So super important to ask about what here? Pregnancy risk. Is she sexually active or no, and any chance you might be pregnant? And ask about contraindication for combined oral contraceptive pills. Why? Because it is not even category 3 and definitely not category 4 for age. So if someone is more than 35 years old or more than 40 years old, it is not contraindicated to give her combined tablet. But definitely if she smoke or BMI is very high, yes, it is contraindicated. But in this case, we stopped it based on the age only, combined tablets. Because one of the options in your management is to offer to put her back on combined tablets, especially if she has menopausal symptoms. Because we can use combined hormonal contraception until the age of 50 for both contraception and HRT. We mentioned that HRT is not a contraception, but combined hormonal contraceptive can work as a contraception and HRT. This is the only exception. We give one tablet for HRT and for contraception, which is a combined hormonal contraception. All right. So this lady, you need to ask about what? Very important here, menopause symptoms as well. Menopause symptoms, very important. And what she would like us to do. Sometimes she tell you, doctor, can you do a hormonal blood level or blood test for my menopause or no, which is the FSH. Okay. And usually keep in your mind, menopause is a clinical diagnosis. So we don't usually do a blood test to check FSH to diagnose menopause. Unless your patient is less than 45 years old with atypical symptoms or less than 40 years old and we suspect premature ovarian failure. So we do FSH, or we do FSH if your patient is more than 50 years old and she's taking progesterone only method. Because we don't know if she's menopause because she is already, or she doesn't have period because of the menopause, or she doesn't have period because of the progesterone only tablet or progesterone only method, either IUS, or either implant or injection. So these are the important questions here. So sexual activity, any chance you are pregnant, and why did they stop the combined tablets? Are you smoking? What is your body weight? Any history of blood clots? So contraindications for combined pills, and asking about menopausal symptoms, and if she takes her tablet every day as prescribed or not. And you can ask about if she's having any other side effects from the mini pills, any breast tenderness, any headache, any weight changes, any acne on your face or not. So how to approach this? So the approach here should focus on acknowledging the patient agenda and acknowledging that it is a valid worries that you don't have period after we started you on the mini pills. But explain it is very common to have no period while we start you on progesterone only method, like mini pills, injections, injections, IUS, or implant. However, given the fact that you are sexually active, we need to rule out pregnancy. Doesn't make sense. Then, depending on the next step, depending on your preference. If you're happy to continue on the mini pills and you don't have any issue of having no period at all, you can continue on that. But if you would like monthly bleeding, we can either put you back on combined pills if she doesn't have any contraindication, she's not a smoker, and it can help with her menopausal symptoms. Or we can give you IUD or copper IUD. You will have monthly bleeding with it, and it will act as a contraception. If she's having menopausal symptoms, so we need to discuss also HRT, because given the fact also you have some menopausal symptoms, we can also discuss the HRT. I'm aware that we may be running out of time, but if you would like another appointment to go through HRT, available options, available contraception options that can be used with HRT, I'm happy to book you, tomorrow or day after if you have time to come. Okay. Pregnancy test is essential in this case. You need to do a pregnancy test. Don't forget that. Also, if you didn't have any issue with combined pills, the combined contraceptive method, and the only thing that we stopped it because of your age is not absolute contraindication, and it is not even a relative contraindication. We still can continue until the age of 50, the combined tablets. So again, options here, either continue or give copper IOD, or if she wants monthly bleeding, or if she wants monthly bleeding, combined tablets. If she's menopause, HRT. And actually, if she's having menopausal symptoms, combined tablets is a good option. It can act as a contraception, and it can act as a HRT until the age of 50. Then we'll stop and switch to progesterone only method. Don't forget again pregnancy test. See, I'm telling you, don't forget pregnancy test, and some of you forget pregnancy test in our mocks. In all menopause stations, there's again good tips that you can tell your patient about. There is, and this is very important in any lady coming with premenopausal symptoms or menopausal symptoms. There is an application called Balance application, as you can see here, Balance application. This application you can download over your phone, and you can track your menopausal symptoms. And there are plenty of information and leaflets about menopause, self-help measures. Okay, and also you can make a report about your symptoms and all of that, and you can bring that report to us when you come for review. Okay. All right. Definitely don't forget safety net and follow-up in any case. So if I didn't tell you while I'm explaining to you the cases that you need to do safety net and follow-up, you need to ask about ice and impact, it doesn't mean you don't need to do that. If you forget safety net in your SCA exam, there is a high chance you will fail the station. That's why it's very important. Next, very good case, which I really love and I really like. And this case, I have seen it before many times. Down syndrome female and coming for contraception advice. So how it comes, I will tell you how I had this case before in my daily practice, and also you may have the same. Down syndrome patient and she was 20 plus years old, about to start her sexual activity, and she's coming with her mom, asking about contraception. Does she need contraception or no? And what are the options? Also, I had it before. She was the girl was 15 or 16 years old, Down syndrome girl, coming with her mom. But if you have something like that, for example, in the SSA exam, it's very unlikely you'll have the Down syndrome patient herself in the exam. So what will happen is, usually it will be mom coming asking for contraception for her girl who has learning disability. Could be Down syndrome girl, could be learning disability without Down syndrome. Okay, so you can have it either way. But I told you how you can have it in your daily practice, and if you have this or similar thing to this in your SSA exam, they will not get you a Down syndrome role player in your exam. But they can get you a case where mom is asking for contraception because her 15 years old Down syndrome girl is about to be sexually active. What is the trick in this case? The trick in this case, first of all, you don't have the patient in front of you. And this case, this girl, she's having learning disability. Super important. And I highlight under super important million lines. You need to ask about partner mental status. Does he have any learning disability as well or no? Does he have Down syndrome as well or no? Why? Because if he doesn't have any mental disability or learning disability or Down syndrome, there's a high chance he will be in a position of superiority. So he can control the girl. And here's the question, is it safeguard or not? So I will complete the case scenario for you. Let's put an imagination about a case scenario. 15 years old or 15 and a half years old Down syndrome girl who met another Down syndrome boy in a party. So her partner has Down syndrome. So there is no safeguard here. Again, second question you need to ask, Mom, are you happy with this relationship or not? Do you think your girl or your daughter or your lovely daughter is safe or not? Do you think your daughter is happy with the relationship and that new boy? Fantastic. I'm just wanted to make sure everything going in the good direction and you are happy with the relationship. Because at the end, we all care about your daughter and we all love to see her happy, having good relationship and so on. You know, all of these words and nice words to show empathy and show that, you know, you are very nice and build up very good rapport. All right. So this is the tip and the trick here. Definitely you need to ask about normal question for contraception and migraine, DVT, blood clot, blah, 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 and so on. But this is very important. Also social history, smoking, alcohol, and so on, okay? So don't forget this. So how to approach, definitely you will acknowledge that it is very important that she came here today and sang here. And yes, Down syndrome females needs contraception. They are fertile. Most of them are fertile and most of them can get pregnant. Down syndrome males, most of them are infertile. But Down syndrome girls, most of them are fertile. That's why they need contraception. Yes, your girl needs contraception. The option depends on her preference. It's not about mom preference. It's about the girl preference. That's why it's very important to involve her in the decision making. I know it might be hard for her, you know, to understand everything in more details, but we will go at her own pace, and we'll go at you know, at her own level, and we can explain simple things to her, and at the end we can involve her in the decision making because there are options available: daily method, long acting method, injection, implant, and so on. Okay, so there are many options available for her. So we need to arrange. So you give the options to mom, you acknowledge the mom expectation. Yes, it makes sense why you're asking for this, because Down syndrome girls are fertile, and there's a chance, high chance, she will get pregnant. So the options available, we have daily method, we have long-acting method. It all depends on her preference. That's why we need to see her face-to-face, engage her in the decision making, and so on. You know, if both parents have Down syndrome, the probability of having baby with Down syndrome is significantly higher than if mom only has Down syndrome. And if mom has Down syndrome, there's a 50% chance that the baby will have Down syndrome. You didn't need to know this statistics, but just for you as a knowledge. Okay, very important. And definitely, if the girl with Down syndrome become pregnant, she will have all the support throughout her pregnancy with all the scans, regular follow-up, and so on. Okay, so you need to offer follow-up appointment where mom will get her daughter to see you as well, and you go through the options with the daughter, and you go at her own level, at her own pace, and you explain things to her, and then she can decide. So involving her in the decision making is very important. It doesn't matter if the girl has Down syndrome or any other learning disability. Involving the girl in decision making is very important. And definitely safety net against what? Stroke, migraine with aura, blood clots, or whatever. Okay, and or any mood changes, and safety net against pregnancy, and safety net against what? If any relationship happened at any point, if you think there is any concerns about this relationship, please seek urgent advice. We are happy to help and support both of you. Okay, I like this case. I like this case. All right, and very important. Yes, so we mentioned in any contraception case, STI. Mom, please be aware that this contraception will not protect her against STI. That means she needs to practice safe sex. And I would ask your help, mom, in this, because you are the close one to her. So I would ask you to give her more support in terms of, reminding her every time to practice safe sex advice. Are you happy for that, mom? Okay. Right. Next. Again, by the way, Down syndrome and contraception is one case scenario. The coming one is another case scenario. But it is again, mom coming asking for a contraception for her daughter with learning disability. Why? Because the daughter has menorrhagia, heavy menstrual bleeding every month, and she's about to start, going to swimming club, about to start going to the college or school, and so on. And mom wants to, suppress her monthly bleeding, or, make the bleeding less heavy, less painful, and so on. So again, mom is asking for contraception, but she's asking for contraception not as a contraception itself. It is just because she knows that having some contraception can sometimes suppress your monthly bleeding. Questions are the same exactly as the previous case of Down syndrome. Where is your daughter now? And definitely you need to ask about how frequent she's having bleeding. Is it regular her cycle or no? Painful or no? Passing blood clots or no? Anemia symptoms? Did you discuss options with your daughter? Is she sexually active or no? All right. Social history for the daughter. Contraindications for different contraceptive methods, especially, breast cancer, DVT, migraine with aura, blood clots, and so on. Did she try anything for her heavy period before, or painful period? Mom is asking for particular contraception, injections. Why? Because mom had injections before, and that 3 monthly injections worked very well for the mom. It doesn't mean if it worked well for the mom, it is the best option for her daughter. We don't like, or it is not the first line option to give young girls injections. Why? Because it can affect bone health over the long term. But it is still one of the options. But it doesn't mean because mom found this option well working very fantastic for her, it will work for the daughter. So how you can explain? Again, acknowledge mom expectation. Acknowledge that, yes, I totally understand that how heavy period how heavy the periods are, and we need to do something about it. Especially, it can put her at risk of having iron deficiency or anemia and so on, and bother her while she's attending her swimming classes or during the college attendance and so on. The good news is there are many options available. If she's happy to take non-hormonal method, like for example, tranexamic acid, mefenamic acid, something that can make her bleeding lighter, we can do that. It is one of the options. Or if she prefers to take hormonal method to suppress her bleeding, we have also different options. There is daily method, there is long-acting method, daily method like tablets, long-acting like one of them, as you mentioned, mom, to me, injections, yes, can be one of the options, could be implant as well, could be IUD or IOS, and so on. But IUD or copper IUD is not the best option here. Why? Because it can make the periods actually more heavy. So I would say go away, please. Any menorrhagia case, try to go away from copper IUD. But contraception case, yes, copper IUD is very good option. But any heavy bleeding case, any heavy period case, go away from copper IUD. Why? It can make the periods heavier. Any transgender patient coming again for contraception advice, don't give copper IUD. Why? It will cause heavy period, and many transgender will not like having heavy period every month. You can offer the option, you can explain, can make the period heavier, but again, it's up to her, the transgender, if she would like to have it or not. So here you have non-hormonal options, you have hormonal options. You can offer also blood test for this lady or this girl because she's having heavy periods to rule out anemia, and offer another appointment to speak to the girl to try to engage her in the decision making. I know, mom, it might be hard for her to understand everything, but again, we'll make everything easy for her. Try to engage her in the decision making. And it is also a good opportunity to see her face to face. Okay, all of this can be. And also, at any point, if she start to have sexual activity or sexually active, you need to let us know so we can, yes, talk about safe sex advice. And if she is not taking any contraceptive methods at the time, we can discuss contraceptive options again with her. Okay. Then menorrhagia cases. Menorrhagia cases, someone coming with heavy bleeding. Again, same. Regular or no? Do you bleed in between your cycle or no? Any postcoital bleeding or no? Anemia symptoms. Any chance you are pregnant now? And very important question in menorrhagia. Are you planning to be pregnant or not? Are you planning to be pregnant or not? I will consider it as one of the most essential questions in any menorrhagia case. Because if she's planning to be pregnant, you cannot give her contraceptive methods. So you give her tranexamic acid, for example, or mefenamic acid, something that will not affect her fertility chances. But if she doesn't want any kids and she's happy to take contraception, yes, it is good. That's why essential question here, are you planning to be pregnant or not? Okay, rule out fibroid, rule out underactive thyroid. Okay, as I told you, anemia symptoms, sexual history is important as well, STI, are you up to date with your smears and so on, as usual. So again, how to explain? Well, this case can come what? How can it come? It can come as menorrhagia case, someone coming with heavy bleeding every month and she wants something to help. Someone, she's having heavy bleeding every month, but she's not bothered about it. However, she's going for a wedding, graduation ceremony, important social event next month, and she would like something to arrest her bleeding while she is in the wedding. Or, and I have seen this many times, someone going for a holiday abroad and they want to arrest their bleeding while they are on a holiday until they come back. So they don't want this, just coming 3 or 4 weeks. They don't want any bleeding from down below until they go and come back. Or it can come as a fibroid case, and you will have ultrasound scan report for fibroid. Important to be aware what is the size of fibroid, because 3 centimeter is very important cutoff point. Because if more than 3 centimeter, we need to refer. Okay. So face to face, definitely you need to examine. the lady, if she's having menorrhagia, could it be fibroid? Could it be anything suspicious? And also vaginal examination, anything from down below could be suspicious. Blood test is very important. Pregnancy test is also important. Pregnancy test is also important. And options available, again, options, as I told you, options depend on does she want a pregnancy or not. Leaflets, you can give her leaflets about menorrhagia, available options available, follow up after a few weeks to see if the treatment is effective, and safety net. If bleeding gets worse, discharge, new symptoms, anemia symptoms, fainting episodes, seek urgent medical advice. Very important in the blood count to rule out anemia and iron deficiency, because if there is an iron deficiency, you need to offer iron tablet. So management based on definitely the cause and definitely depends on if she would like to be pregnant or not. So if no pathology, fibroid less than 3 centimeter, first line usually IUS, but making sure she doesn't want pregnancy. She would like contraception. So the first line, IUS. It can take up to 6 cycles until she can see a good effect. If she doesn't want, tranexamic acid or non-steroidal can be a good option, or other options, combined tablets as well, or even progesterone only tablets. All of this can help with menorrhagia. If she's having fibroids 3 centimeter or more, we need to refer, and in the meantime, we can give tranexamic acid or mefenamic acid. Okay, very important. Then in the fibroid case, because it is another case scenario, how you can explain fibroid to the patient, it is growth that can form in or around the womb. Very common, not dangerous, and some women don't notice them. But sometimes they can cause heavy periods, tummy pain, affecting your fertility, or feeling pressure down below. The good news is there are many ways to treat fibroid. Also, leaflets, British Fibroid Trust can give you also good information about, or this I will send you a website, British Fibroid Trust website about what is fibroid, why you have fibroid, different treatment options, how can it affect you in terms of your fertility, in terms of your symptoms, in terms of your menstrual cycle and the bleeding every month, and so on. All right. Definitely, if your lady is having fertility issues and we found she's having fibroid, you need to refer to fertility clinic as well. Okay. So if menorrhagia causing low iron, definitely we need to give iron tablet. An iron tablet, side effects, constipation, black stools, stomach pain, discomfort, and so on. So iron tablet, if she's taking it, don't take it with tea or coffee or calcium because it can affect the absorption. And best thing to take iron tablet with lemon juice, orange juice, or vitamin C tablet because it can increase the absorption of iron. All right. Then, as I told you here, you may have a patient, again, super important because it could be a different case scenario. Menorrhagia case scenarios, as I told you under menorrhagia, 3 or 4 different case scenarios. All of them are common daily practice cases. That's why you need to be aware of them, please. So, if someone already started to have bleeding, okay, we can give either tranexamic acid, 1 gram 3 times a day for 4 days. That can make the bleeding less. If she's having bleeding and pain, you can give mefenamic acid. And you will find here the side effects for everyone. Why? Patient can ask me in the exam, what is the side effects? If someone has heavy bleeding also and we need to arrest the bleeding, another option, northisterone, 5 milligrams 3 times a day for 10 days. That will arrest her bleeding. And if she's going for a holiday, she can use this tablet. Or if she's going for a wedding or ceremony or graduation ceremony, she can use this. But northisterone tablet, caution if her BMI is more than 30 or if there is any history of DVT or VT risk. Okay, also, if she's pregnant, we cannot give. Any liver disease, active liver disease, or breast cancer, we cannot give. Side effects, bloating, breast tenderness, and so on. To delay her period until she go on a holiday and come back, she will take northisterone 5 milligrams 3 times a day, 3 days before expected period, and until she come back. Okay, from the holiday. And once she stop it, after a few days time, after 3-4 days, she will start to have bleeding. Okay. Again, for northisterone, caution if BMI more than 30. Because if BMI is more than 30, better to take medroxyprogesterone 10 milligrams 3 times a day. Okay. or if there is any, high DVT risk or family history of DVT, she can take this one. Right. And if she is already on combined oral contraceptive pills and she doesn't want a bleeding, don't take that 1 week off. Take it back to back. Take it back to back. Okay. All right. Menorrhagia, if someone is taking lamotrigine for epilepsy, again, just read this. Read this. What are the good options for her? Definitely, you will not offer a copper IOD because, as I told you, copper IOD with menorrhagia, it will make it worse. But what you can offer, for example, iOS, which is the best option. Tranexamic acid non-steroidal also can be an option, or progesterone only pills as well can be an option. Then intermenstrual bleeding could be also a case scenario. Don't forget, intermenstrual bleeding can be a sign of STI. Can be a sign of STI. That's why if you have 19, 20 years old girl coming with intermenstrual bleeding, you need to ask about the STI symptoms, any discharge, any offensive discharge, how many partners, if your partner has any symptoms or no, any pelvic pain, especially on one side, any fever, any shivery, any offensive discharge, and so on. Very important. Any UTI symptoms as well, because you need to offer swabs and urine dip and urine test, and offer face-to-face to examine her pelvic as well. Okay, don't forget, intermenstrual bleeding can be a sign of STI. Very important? Yes, very important. Okay. So that is for different case scenarios for menorrhagia, including intermenstrual bleeding. All right. Next. So next is primary dysmenorrhea case. Primary dysmenorrhea case. You know, dysmenorrhea can be primary or secondary. That's why it's very important if you are having a dysmenorrhea case in your exam to ask about, is it since you started your menarche, or you started your menarche, no dysmenorrhea, and few years after you started to have painful period. So you need to clarify, is it primary or secondary? Secondary dysmenorrhea, usually there is underlying cause. Usually there is secondary cause for it. Whatever the cause is, fibroid, infection, whatever. So I will give you a case scenario so you will understand what we are talking about and what is this case scenario is about. So let's say you are having 14, 15 years old girl. Again, you will having a chat with mom. Mom is coming to you, doctor, my daughter, she is going to college or having a competition, and I need something to help with her periods. They are very heavy or they are very painful. So here it is very painful. So you need to clarify, is it only painful or it is heavy as well? Because if it is only painful, so we can give maybe some non-steroidal anti-inflammatory. But if it is heavy as well, or she's sexually active, so combined oral contraceptive pills or any hormonal contraceptive methods can help, either the combined one or the progesterone only one. That's why very important. And as we mentioned before, if you are talking to parent, you are not discussing the with the patient straight away or directly. By the way, it doesn't matter. Again, listen carefully, please. If you are discussing with a third party, it doesn't matter, carer, care home manager, paramedics, mom or dad, and you are not talking to the patient straight away, you need to ask, where is the patient now? Where is the patient at the moment? And why they are not talking to you? So you need to ask about age of menarche and is it sensitive or not. Clarify more about her pain. Where does it hurt exactly? Does it go anywhere else? Anything that make it worse? Anything that make it better? Any other associated symptoms and so on. Then ask about period, regular or no, heavy or no. Did she try any over-the-counter medication or no? Definitely impact is very important, and rule out other causes like any pain in between the cycles, any discharge, any irregular bleeding, okay, or any bleeding between the cycle. Very important. And we always say also it's good to ask about bowel and urinary symptoms in woman health cases, because fibroid can compress bowel and the bladder, give her also bowel and urinary symptoms. Very important. Okay, very important, very important. You need to ask about what? Sexual health, sexual activity, if she's sexually active or no. So how to explain this with the mom? Again, we need to involve the girl. Mom can tell you the girl is still young, she may not understand everything. Even if she doesn't understand everything, it's always advisable to engage her in the decision making. We'll try to simplify things to her. And also it's very good to examine her as well, to make sure there is no any lumps in her body or her tummy, no fibroids, nothing like that. So how to explain this is primary dysmenorrhea? Try to definitely say this the diagnosis. Diagnosis is a part of history taking, but we always prefer, or our approach in the team, tell the diagnosis and address the agenda first line in the management. So first line in your management is always addressing diagnosis, telling diagnosis and addressing the patient agenda. All right, so this sounds likely to be primary dysmenorrhea. Why? Because her pain and discomfort started since menarche, and it happens every month in the same way and at the same time. And no any other red flags or no any other thing can tell me there is underlying secondary cause. That's why. All right. So please be careful because you need to clarify, is it only painful or painful and heavy period? Very important. Please don't forget this. So the first step usually to give some non-steroidal anti-inflammatory drugs like ibuprofen, for example, mefenamic acid. If it is heavy, you can give also non-hormonal. So we have hormonal, non-hormonal. But if it is also heavy and painful, we could consider hormonal option. Why? Hormonal option can make her periods lighter, less painful, more regular if it is irregular, and if she's sexually active, it also add another thing to her as a contraception. Very important. But again, because she is 14, it is important to speak to her directly as well. Okay, give her some time to talk on her own. So I would like to see her to give her some time to talk on her own, express her also feelings, express what she wishes. We'll offer her the options, and it is better to listen also her point of view, her wishes, and so on, to involve her and engage her in the decision making. Very important. Okay, I would be more than happy to book for her another appointment to engage her in the decision making and listen to her preference. So again, we have non-hormonal, we mentioned about that, or we have hormonal options. By the way, we can give her non-steroidal along with tranexamic. Also, hormonal options can be combined pills, can be also other hormonal options. It depends on her preference and if she has any contraindications. Okay, so best to arrange face-to-face. What she can do by herself as well, like self-help measures, heat bath, hot water bottle. Start pain relief or painkillers early. And keep a diary for her period and her pain. If there is any other triggers, for how long each episode of the pain lasts, what did she do before that, what did she take for her pain episode, did it help or no, how severe her pain is, significance of the pain and impact on her life. All of this can be in the diary. Also encourage school and activities and her competition or whatever sports as to related. And safety net, if it gets worse, or any other red flags, like any discharge down below, bleeding becomes more heavy, irregular period, or pain in between the cycles. And follow up definitely after a few cycles to assess how she is responding to the treatment and to review her symptoms to assess her symptoms. Please don't forget. Please don't forget. And we always say that if you got patient with heavy period, always ask about anemia symptoms and always offer full blood count. You can also offer clotting screen. Very important, okay? Next case is premenstrual dysphoric disorder. We mentioned about that in the general approach. And I told you that usually ladies or girls in the 1 week or 2 weeks before the bleeding starts, you will have physical and mental symptoms. Could be bloating, breast tenderness, body aches, stomach pain, could be some depression, irritable mood, poor sleep, and so on. Sometimes even it could be really very depressed mood and suicidal as well. That's why you need to ask about all of that. You need to ask about menstrual history, contraceptive history, sexual history. You need to ask about mental history and mental health, suicidal thoughts, all of this. Who is at home, support network. Did she try anything before or not? All of this is very important, and timing is very important. When exactly in your cycle it happened, how long it lasts. Usually it lasts, as I told you, 1 or 2 weeks before cycle or before the bleeding start, and it will get better once her period starts. It will improve once the bleeding starts. Okay, so how to explain? As I told you, it is a syndrome where emotional or mental and physical symptoms happen 1 or 2 weeks before the period start and improve once you start bleeding. It can significantly affect your mental health, your physical health, your daily function, and so on. But the good news is always to be optimistic. The good news is there are many ways to help and support you with. So management, as usual, Imtiyaz approach is very easy. Addressing eyes and diagnosis first line. And we are the first people to talk about how you can make your consultation patient-centered by addressing eyes and telling the diagnosis first line, and then offering options. We have few options here. Let's find out together which one you prefer and so on. So lifestyle option is very important. Things that you can do by yourself. Regular exercise, eating healthy, good sleep hygiene, reduce caffeine, cut down alcohol and smoking, stress management, CBT, talking therapy as a self-referral, all of this. Track your symptoms, symptom diary, for how long your symptoms last, any other triggers, what did you do for your symptoms, the impact of your symptoms on your daily function, and so on. Medical treatment. So if the physical symptoms is the dominating part, you can offer non-steroidal for the physical symptoms. But if the mental symptoms is the dominating part, you can offer SSRI. And SSRI can be on a daily basis, long term. I mean, like for a few months or 1 or 2 years. It depends on her response, or it can be only in this 1 or 2 weeks before her bleeding start. So it could be only in this 1 or 2 weeks before the symptoms, before the bleeding start, when she has those kind of symptoms, or it can be daily basis. Okay, throughout all the cycle, every day she will take SSRI. Also, referral for the mental health team can be an option, especially if there is any significant depression, like severe depression, or suicidal thoughts. Combined oral contraceptive pills also can be an option here as well, especially if it is very painful period, very heavy period, and so on. Leaflets, you can send her leaflets and follow up definitely after a few cycles to assess her symptoms, to assess her response, if we need to adjust our treatment plan or not, is also important. And safety net, if worse, not coping at all, suicidal, any new symptoms, please come back straight away. Then the coming 2 or 3 case ideas are super important. And I have seen this before, by the way, many times. I used to train in an area where there are many homosexual people. So let's say you are having here mom or dad coming, and let's say mom coming. Why? Again, you are talking to mom. She's worried about her daughter. Her daughter started to act weird. She says, her name is Sarah. Don't call me Sarah anymore. My name is William. I'm not Lucy. My name is David, and so on. So daughter started to act as a male. Mom is concerned. What is happening to her daughter? Is it something short term or long term? What she needs to do? She's coming asking for an advice. Very important here. So what are the questions you need to ask? You need to be very empathetic, very supportive. Normalize the topic. It's quite common. We see that very often here, but don't worry. The good news is there are many ways to help you and support you with. There are many things that we can do for you as a mom, and for the family, and for her as well. You are not alone in this. We are here to help and support you in any way we can. So in terms of her daughter, how long has your daughter been experiencing this feeling? Duration. What are your concerns, mom, about your daughter? Did you speak to your daughter or not? How is your relationship with her? What about the other family member? Is there any good relation between your daughter and all the family member or not? Okay, very important. Very important. Okay, how is situation at school? Does she have any friends? Did you speak to the school team? Did the school team raise any concerns with you? Did you communicate your concerns with the school team or her teachers or not? Very important. Home situation is very important. Any other kids at home is very important. Okay. Any stress at home? How is the reaction from other family member? Then Mom, are you calling her with her preferred name or not? Because it is also important, to do that. Then, very important to ask about, as we mentioned, school situation, and don't forget bullying in the school. And has anyone affecting her decision? Do you think there is anyone that can be affecting her decision? Anyone? Do you think of anything that may affect her decision? Someone is pushing her to act that way or not? And very important, are you aware that if she's taking any hormones for transgender or not? Okay. Also very important here to ask about what? What do you think? So she is a female and she's trying to explore herself on the opposite sex. Okay. So it is very important to ask about secondary sexual character, like breast development, also her periods, if she's taking any contraception, if she's having any relationship, either homosexual or heterosexual relationship. Also is very important here to ask about alcohol and smoking or recreational drugs. I know this case is challenging. Why? Why? Here, it is one of the cases that you need to address two things. You need to address your patient herself, which is the main part of your consultation, but don't forget there is some stressful situation that is affecting mom, affecting family. You need to acknowledge this, and you need to offer support for mom and family. It's not only about your patient. It is a family approach. It is a family approach. So try to practice on this case many times, because you need to practice how you can address many things at the same time. Here there is double eyes. Eyes, if the daughter is worried about something, okay, or if the daughter is hoping for anything in particular, and eyes for the family or eyes for the mom. Very important, please. And again, please don't forget. So how to approach this? Again, acknowledge the impact of that on the family. Acknowledge the impact on the daughter. Acknowledge how stressful it is, especially it is the first time to happen for you. And especially you have other kids and you are worried what you can do with other kids as well. But don't worry, there are many options to help you and support you with. So your daughter may be exploring her gender identity, which is a normal process for some young people. It is important to provide what? To provide here. It is a rule of the family now. Provide safe and supportive environment for her. Gender identity, okay, is deeply personal. It is not uncommon for young people. It is fairly common to express themselves differently as you grow up. Mom, it is normal to feel overwhelmed when your child expresses a different gender identity. The most important thing is to provide her with a safe, loving environment or support she needs. As a family as well, you can show support by using her preferred name, learning more about gender identity together, and ensuring she knows that you are always there for her and you still love her. There are professionals and support services that can guide you through the journey and support you, the whole family, and her as well, your daughter as well. What about, listen carefully, please. What about if mom will tell you, doctor, it is something temporary or it is something long lasting? Well, it might be something temporary. As I told you, many young people, when they grow up, they start to express themselves differently. But in many of them, it is just a temporary phase, and then after that, they will come back as before. But for some of them, it might be long lasting. That's why all we need to do now is to offer her all support she needs. What you need to do at that point? You need to address the mother eyes, definitely. This is the first thing. Her eyes is something temporary or no, what should I do? What she can do, we will come to this, but we'll mention about something. Supportive environment, make sure you have a good communication with her, try to learn more about gender identity with her, call her with her preferred name, buy for her her preferred clothes, and so on. But what we can do as a GP? Here it comes. We need face-to-face. Please don't forget face-to-face. Even I remember in one of our mocks, the role player told your colleague, after the colleague made a very fantastic plan, but he neglected completely the patient. So the role player told him, doctor, you don't want to see her at all. So he realized that, oh, I should speak to her as well to listen what her thoughts and what's in her mind. So yeah, why not? So bring her, please, next time with you. Okay. So that kind of role players, you may have something like that also in your exam. And the role player will tell you, doctor, you don't want to see the patient, or you don't want to see me if you are talking to the same patient, and so on. So face to face to see the patient. And if you are talking to the parent, definitely advise that I would like to speak to her. Listen to her, thoughts, ideas as well. And, sometimes, or it may be also advisable to ask your mom to go outside for a couple of minutes just to speak to her by myself, just in case if there's anything that she would like to tell me and she doesn't want you to know about it. Also, mom, supportive listening, open communication, as we mentioned. And we have two options here. Either we refer her now to gender identity clinic and gender identity service. Referral can take some time, and it can take, up to even 1 year sometimes in some areas. In the meantime, we'll keep eye on her. At any point, if she changes her mind, we can cancel the referral. Or if you would like to wait for a few months' time, if she still has same thoughts, so we can go ahead with the referral. What do you think, mom? Then if there is any significant stress or significant impact on the mental health for the daughter, we can refer to camps. School support is very essential. Mom, I highly recommend if you can speak to her teacher. And especially if she has a preferred or favorite teacher in the school. They can offer her lots of support. School here has a very important role. School here has very important role. Okay? Not only this, parent support groups. Mom, I know how frustrating is it for you, how challenging for you. Don't worry, there are many local communities and local support groups where you can meet other families who have kids in the same scenario and same situation. So you can meet them, share your experience with them, learn from each other, support each other. That will make everything very easy for you. Are you happy to link you to some of the groups? One of them is Miramaid's UK. Miramaid's UK. I can send you the link, and you can also look for the local communities. Follow up after a few weeks or few months again to see how everything is going. Is it something temporary, or still she's having same thoughts? And safety net. If any severe distress, mom not coping, any concerns, please seek urgent medical advice. This is the first thing. Mom can ask you, or the daughter, or whatever. So the patient or the mom can ask you, doctor, what about chest binder? Chest binder. She's a female. She's not acting as a male. She need to hide her breast. What about chest binder? Is it safe to use or not? So chest binder can sometimes help with body dysphoria, hide the breast, but she needs to look for the correct size, take regular breaks, and avoid wearing chest binder for more than 8 hours. And avoid chest binder during exercise or sleep. Remove it if she is doing any exercise or sleep. Okay? It can cause some skin irritation, can restrict the breathing a little bit. That's why don't use it while you're doing exercise and sleeping, and also can cause some, chest pain and back pain from the pressure. So that's why not very tight. Don't use it for a long time. Check the correct size for hair, and don't use it for more than 8 hours. Take regular breaks. That is for chest binder. Don't forget. So you can also read more about options for the mom and the family as a support. Phrases as well. You can use also some phrases. Here's many phrases as well. You can read them, select which phrase is easy for you to utilize. Let's say you probably have this even station and you don't know what to do. You probably also can tell the mom, I will share with you some other resources like YouTube videos, TEDx, videos about families sharing experience about their kids who had the same phase, or they had sort of the same, experience. So you can learn from them. And by the way, you will find on YouTube, you will find, on TEDx and so on, many people, either the patient or the family, sharing their experience with this kind of thoughts, this kind of transgender, and so on. Next is, it can be also another case scenario. you may have patient, and had this before, exactly the same. Patient, transgender, she fed up. Referral time, and she was referred 1.5 years ago. She's still not been seen, and she's coming asking for estrogen. Okay, asking for hormonal treatment for her transgender or testosterone. Transgender people, either estrogen or testosterone, it depends on which gender they are moving to or switching to. Some of them will be taking that hormonal treatment from black market. Some of them, they are not had yet any hormonal treatment, but it is significantly impacting their mental health. Same questions about effect on their mental health, about the relationship, about contraception, about suicidal thoughts, self-harm thoughts, if she was seen before or not, support network around here, social habit as well, recreational drugs, and so on, and if she's taking it from black market or not. Then, very important to be clear, as a GP, we don't have much experience to deal with transgenders. That's why there are gender identity clinics with specialized or with many doctors who are specialized in transgender treatment. I know how frustrating for you, and if I am in your place, I would be exactly the same, frustrated, fed up from the long waiting time. However, it is about being safe. I know it is a tough journey, but don't worry. What we can do from our side, we can send expedite letter. We can chase it for you. And I know it is impacting your mental health. We can talk about ways to support you and your mood during that time, either by medications or referral to mental health team. The issue with hormonal treatment, it needs specific doses, a specific titration, a specific monitor, and a specific follow-up. That's why it needs to be under secondary care or under a specialized clinic. Not anyone can do that. It's about your safety before everything. Does that make sense? I know it is also frustrating for you, but if you would like, I can link you to local communities, local support group where you can meet other people with the same experience, supporting each other, sharing the experience, and so on. If you reach nowhere with your patient and she still insists or he still insists on hormonal treatment, what you can say, okay, I can see how frustrating is it, and you still insist on that. I'm here trying to help you. I'm not against you at all. I'm here trying to help you in each single way I can. What about if I can contact the gender identity clinic, explain everything? If the advice on giving you something in the meantime as a risk minimizing, okay, especially you are taking it from the black market, which is unsafe, totally unsafe. If the advice on something that we can give, I will come back to you. If they accept to see you sooner than later, I will also let you know. Does that make sense? And so on. So try to be nice. Try to acknowledge the frustration, acknowledge the impact. Try to tell the patient, I am on your side. What I can do from my side, I will definitely do it for you. Why? You are my priority. I know how frustrating for you. I know the waiting time is quite long, and I know you started to take this from the black market and so on. But as I told you, it needs a specific dose, a specific titration, a specific monitor, because it can have side effects. You know, even testosterone can have serious side effects, can cause polycythemia, and polycythemia can have multiple complications, and so on. Then, before my SCA exam, when I had my SCA exam, I didn't know anything about transgender services. After my exam, I started to read about what kind of transgender service is available there, or people who are homosexual. I discovered there are plenty of them. As you can see here, Miramates, the Proud Trust, LGBTQ Foundation, Switchboard LGBTQ, Mind Out, Flag, all of this are services. You don't need to remember all of them. Just know one or two to be aware of this, to signpost your patient to in the exam. So select one or two, and that's it. Then another case of transgender. Let's say, again, let's fabulate a case scenario for you. Let's say you are having a transgender patient. This patient had a breast reconstruction surgery as a part of the transgender, and she's under gender identity clinic or service. This patient, after being away from work as a sick leave for the surgery and so on, they came back to work and they started to have they feel uncomfortable at work. They feel uncomfortable at work. Maybe the work environment is not as supportive. You need to rule out again here any stress at work, any pulling at work, because this is very important here. Then, again, they started to have also breast pain. After that breast reconstruction surgery, they started to have breast pain. Is that breast pain? Is something, like infection, for example, or it is just from the scarring or healing process? We don't know yet. So there is breast pain after breast reconstruction or reconstruction surgery, and your patient has unfriendly work environment. So in terms of breast pain, you approach it as any pain. Where is it? Redness, hotness, tenderness, swelling, discharge from the wound, one side or both sides, systemic symptoms, any axillary lymph node or any axillary lumps under your armpit, and so on. Does it go anywhere else in other symptoms? This is the breast part. Why? We need to see her or to see him face to face to examine the breast to make sure there is no any infection and so on. This is one thing. Second thing, which is important, is work environment and mental health. Mental health here is super important. Impact or not? Suicidal or not? Any self-harm or not? Bullying at work or no? Did she speak to her employer and HR or no? What was their reaction? Did you offer her any support or no? Social history as well in terms of alcohol, recreational drugs, because many of this are from stress. They start to have more alcohol, smoking, and some recreational drugs. Again, here, what you need to do in how to explain, how to approach, acknowledging how frustrating, acknowledging how challenging, acknowledging that she needs to have all support she needs at work. Under UK law, she should have all support. If you want, we can write a letter to your employer, or you can speak to your employer directly or HR by yourself first and see. And if you need our help, we can write a letter to support you. Seek note if you want. Okay, in terms of your breast pain, we don't need to miss anything, especially you had recent surgery. What about if you can come for face-to-face? Are you happy for me to book for you another slot for face-to-face so I can examine your breast, make sure there is no any infection symptoms, no any scarring, and it is healing nicely? Is that okay? If you are in pain, painkiller. Stress and mental health, CBT, self-talking therapy, maybe some medications, and if significant, depression, we can discuss about also referral if with medication and talking therapy you are not getting better. What about Transactual UK? It is also another charity that can link you to local community, local support group, so you can meet other people with similar experience, supporting each other, learning from each other. All of this can be. And follow up after some time. Usually after a few weeks' time to see how everything is going. Okay? Patient can ask you, which toilet I can use? Even either this case or the case where you are discussing with the mom and she's telling you, which toilet my daughter can use in the school? Well, she can speak to the employer if she can use the unisex toilet, if that will make her more comfortable. There is no any clear answer. But yeah, you can speak to the employer. You can speak to the school. If she is happy to use the unisex toilet, if she feels more comfortable with, yes, she can do that. Okay. Then one of the cases, this case I don't like. So as we are going through the course curriculum and course cases I like. I usually like woman health, all of the cases, but rarely I will tell you I don't like specific cases. This is one of the cases I don't like. So this case, sexual avoidance or sexual dysfunction after trauma. What is that trauma? Right, please, rape. Let's say you probably have a patient coming from, whatever the background. Let's say African patient, for example, because they are quite hard. Sometimes I feel like we are all or most of us, or many of us from Africa. So sometimes African people are quite tough to understand their inner feeling. That's why, let's say you are having African lady coming with low libido. Doctor, I'm struggling with my intimacy with my husband. What do you mean? Well, I lost interest in sex and my husband advised me to come and see you. So for how long did you have this? Was it gradual or it came back as a sudden? Is it all the time or comes and goes? Is there any physical discomfort or any painful sexual intercourse, any discharge from down below? And then you need to be very sensitive here. This patient will not open up to you. Okay, even it is one in our mocks. We even giving the rope lab strict instructions. Don't tell there was a rape in the history until the patient or until the doctor will ask you nicely. How you can ask nicely? How you can ask nicely? So keep it in your mind. If you have patient coming to you telling you, doctor, I lost intimacy or desire to have sexual intercourse, ask about triggers. Sometimes, as you can see here, even I highlighted for you here, sometimes things from the past can affect how we feel right now. Have you ever experienced something distressing that might be affecting how you feel about sex or intimacy? How is your relationship? How is your partner? Is he supportive or not? Did you speak to him about how you feel? How is your mood? Any self-harm, suicidal? How is your sleeping and eating? Then, when you ask about triggers or did something happen recently or something like that, okay, or some traumatic event or distressing event that happened before this started, I'm here to help you in any way I can. If she tells you, yes, I had a rape, this lady, she was walking at night and then she had a rape. She was coming back from work, whatever her work is, and then she had a rape. She was sexually assaulted. And since that time, she started to act that way. Very important. Because of that traumatic event, you need to rule out post-traumatic stress disorder. I'm not telling you the diagnosis, that's why I didn't write here. It is PTSD after rape. No. But I'm telling you, try to be flexible. I'm try to be flexible because if the lady will tell you I have flashbacks, I avoid now going through specific routes or specific ways in the streets because it reminds me about what happened before. I have nightmares and flashbacks, all of this. So it is PTSD. But if she doesn't have PTSD, it is normal reaction. You still didn't adjust about what happened. So it is normal reaction after this traumatic event. But the good news is there are many ways to help and support. So if she tells you I had rape, also there are certain questions to ask. As you can see here, there are plenty of questions here. This is one of the few cases, I would say, that your history taking probably will go even beyond 7 minutes. And if you are fast, it might take exactly 6 minutes. So if someone had rape, you need to ask about definitely STI symptoms. If she's using contraception and when his last period, if any STI symptoms at the moment. And did she report to the police or not? Did or does she know who raped her? Is it a known one to her or not? Do you feel safe at the moment? Did you speak to anyone at all? Very important to ask about expectation. What you are hoping for me to do for you today? Are you looking for emotional support only at this stage, or you are hoping also to report this and escalate this to the police or SARC team or other services as well? Very important. Okay. Social history, definitely. So here, how to approach, you need to acknowledge how she's feeling and why she's feeling that way. It's very expected to have such, an experience and avoiding sex after, after what happened to you. It's not your fault. And no one here can blame you at all. Anyone in your place will feel the same. But I'm very glad that you came asking for help. Because for sure, there are many ways that we can help you and support you with. You are not alone with this. Let's find out together what we can do for you. So you can feel safe, you can feel supported, and to rebuild your confidence about sexual intercourse and improve your, sexual relationship. Okay. So what you can do for her? So if she would like to report to the police, that's really good. We can report to the police. We can report to SARC as well. If she doesn't want, it's totally up to her. But the main part of treatment is psychosexual counseling, CBT and psychosexual counseling. And if she tells you, I have nightmares, I have flashback, avoidance, because it reminds me, avoidance of walking the street in certain times, certain places, and so on. All right. So you approach it as PTSD. But if no, there is no need to mention about PTSD here at all. Normal reaction after what happened. Anyone in your place will feel that way. Also, what we can do for the patient. STI screen. Talk about contraception if she wish. Give her crisis number, especially if there is any mental breakdown or she feels overwhelmed with too many thoughts in her mind about to hurt herself, or she would like to speak to someone straight away. Okay. And follow up after a couple of weeks time to assess how is her mood, how is her emotions, if she started to have counseling or no, and if she would like to talk about anything at all. Okay, very important. Also, there is something called independent sexual violence advisor. Also, he can also tell her some tips and advice how she can act in such situations and what is expected, all of this. Very important, okay? Try to be very, very nice. So SARC can offer her psychological support, some services and advice, medical care as well, full STI screen, emotional support, and so on. Okay, that is what SARC can offer here. SARC is Sexual Assault Referral Center. My preferred cases. Now back to my preferred cases, full of options and so on. Urine incontinence. Urine incontinence. So urine incontinence usually will be lady, probably 40 plus, 50 plus, usually more than 50 or 60, but it can come at 40 plus. It depends, especially if there is significant obesity, multiple, normal deliveries in the past, and so on. I have seen this before in 40 plus. I have seen this before in 50 plus, 60 plus, 80 plus, 90 plus, all of it. Very common. Almost on a weekly basis, I will have a patient with urine incontinence. What is important in urine incontinence? Again, if you remember in men's health chapter, we said anyone coming with urine symptoms, incontinence, dysuria, okay, loot symptoms, you need to offer urine dip and face-to-face. All right. So this patient, you need to ask about definitive duration, progression, any triggers, coughing, for example, laughing, exercise, and so on. You need to ask about urge symptoms and stress symptoms. It is mainly about, you feel you need to rush to the toilet straight away, the urge feeling to wee, or it is also you leak urine, or accidents if you laugh, if you cough, if you sneeze, and so on, or both of them, because it could be mixed incontinence. And if the patient will tell you it is both, I have urge and stress, you need to ask which one is bothering you more. Why? Because it depends on which one is bothering her more. You treat that one first. If the urge feeling is bothering me more, you start with urge incontinence treatment. Or if the stress feeling is bothering me more, the stress symptoms, every time I laugh, jump, walk, run, cough, sneeze, I will leak some urine, this is bothering me more, you start treating with a stress type. Bowel and the bladder. Don't forget, how is your bowel habit in constipation? Definitely, lifestyle here is very important, especially fizzy drinks and dehydration and caffeine. What else? Obesity is very important, or if she's training too much. Smoking as well. Because smoking can cause chronic cough, and chronic cough also can worsen the incontinence. What else? Deliveries before. How many times you have been pregnant, mode of delivery. All of this can affect. Definitely UTI symptoms is important. UTI symptoms is important, and also rule out Kodak wine. Very important, and please don't forget, because I know you will forget. So please don't forget. Please don't forget. If she is postmenopausal lady, you need to ask about topical vaginal symptoms, any dryness down below, any irritation down below. Very important. Okay? Because it can be one of the symptoms of genitourinary symptoms of menopause. Very important. So there are many things here that you can actually read, but most of them are to the point. What is stress incontinence? It is kind of incontinence or accidents or leaking urine when the pelvic floor muscles that support the bladder are weak, causing leakage with pressure like straining, coughing, or sneezing. That is stress incontinence. What is the urge incontinence? Caused by overactive bladder muscles that contract too often or suddenly, leading to a strong urge to wee. With the correct treatment and exercise, symptoms can improve quite dramatically and significantly, even resolve in some cases. It may take some time to find or to notice improvement, okay? But there are many options that we can help and support, and you can start as soon as possible. Okay? So definitely addressing the patient agenda, telling her diagnosis. So addressing eyes and diagnosis is always the first line in your management. First line in your management, eyes and diagnosis. That's it. So face to face, examine the stomach, feel the tummy, pelvis, maybe examining her vagina if any topical symptoms, any dryness, any patches, and so on. Then urine dip is essential. Please don't forget urine dip. And also bladder dial, okay, for at least 3 days. And give options of treatment referring to urine incontinence clinic, follow-up, and safety net. So what patient can do? Self-help measures or lifestyle advice, definitely lose some weight, reduce caffeine, fizzy drinks, alcohol. If constipated, treat constipation. If she's constipated, definitely increase fluid intake, especially in the morning time. Because if she has nocturia, try to cut down fluid in the evening, but keep yourself well hydrated in the daytime. And also make sure you are eating, plenty of fiber. Then exercise depending on what kind of incontinence. Is it urge incontinence or stress? So for urge incontinence, okay, there is specific exercise. For example, the bladder training exercise. Increase the time between weeing. So instead, if you used to wee every half an hour, try to make it every 1 hour or every 2 hours, and so on. That will increase the bladder capacity with time. Okay. Also, very important, some medication. So self-help measures, some exercise she can do by herself, some medication option, like mainly anticholinergic. Very important, and again, it is very important question actually. Write it down or highlight it. I think it is already written in front of you. If your patient is old lady, you need to ask about if she is at risk of falls or if she is known to have falls. Did you fall down before or recently? Why? Because some medications can be used, but these medications can increase the risk of falls because it may affect your blood pressure, makes you drowsy a little bit. That's why. So anticholinergic like oxybutynin can make you constipated, dizzy, and so on, or mirapigrone. And mirapigrone, as we mentioned before, you need to monitor blood pressure. Definitely follow up after a few weeks to assess how symptoms are, if she's responding to the treatment. And when you refer, definitely if there's any significant impact on the quality of life. What about stress incontinence? Again, self-help measures, same, but there is pelvic floor exercise or Kegel exercise. Usually try to contract the pelvic floor muscles 3 or 4 times a day, okay, to build up strength in your pelvic floor. And you can even use your hand to explain to the patient. Imagine that your pelvic floor is like my hands now, and your bladder on top. So the idea is your pelvic floor muscles are weak. And it could be weak because you had normal delivery before, you have been pregnant before many times. Also, with age and all of this, so those muscles can get weaker with time. That's why you start leaking some amount of urine. So our target here is to increase strength in your pelvic floor muscles. How you do that? Try to make some self-contractions few times a day, every day. With time, those muscles can get stronger over time, and that can support your bladder more, and you will leak less. And in many cases, it will resolve. Medication option, duloxetine can be one of the options. Can be. What are side effects? Also dry mouth, feeling sick, and so on. And also follow up the same after a few months or after a few weeks. How you can explain those exercises? You can also hear. For example, pelvic floor exercise or Kegel exercise. Imagine you are stopping yourself from passing urine. Squeeze those muscles, hold for 5 seconds, and then relax. Aim for 10 repetitions 3 times a day. Over time, muscles will get stronger. Bladder retaining or bladder training exercise. Both are correct because we are trying to increase the retaining quality or retaining capacity of the bladder over time to hold more urine and to increase the weaning time. So involve gradual increase the time between urinating, aiming for 3 to 4 hour gap. Why? Because it will help the bladder to retain and hold more urine. Okay. Bladder diary at least for 3 days. Okay. Bladder diary at least for 3 days. In the diary, we can spot on the specific pattern of your urine incontinence. How often do you have this? How much urine did you wee? How much water did you drink? And so on. All of this. Okay. Sign posting, we have Bowel and Bladder Charity or Bowel and Bladder UK. Okay. To give her more information about what is urine incontinence, treatment options available, and so on. Sometimes patient will come and tell you, doctor, I need a quick fix. I have important ceremony, wedding, graduation, and so on. Well, it might take some time to find good benefit and to find significant improvement. However, there are some options that we can start as soon as possible. So exercise, we can start as soon as possible. By the time of your wedding or your ceremony, you can get some improvement. Also, there is something called a pethary or incontinence ring. Just something to fit from the vagina to hold, the top of the vagina. So there is, we say it even vaginal inserts available over the counter, designed to provide temporary support to the urethra during activity, which can help to prevent leakage. Or pethary or incontinence ring also can be fitted temporarily to provide support to the bladder neck and reduce leakage. So from the vagina, they fit it to support the bladder ring. It is a tiny ring. It can be a temporary solution until you go for your ceremony. Okay, some clinics can do it, or gynecology clinic can do it. Also, advice here, also what you can do on the day of the wedding, try to minimize water and caffeine and fizzy drinks intake. We straight away before you attend that ceremony. Wearing bladder, that incontinence pads, high absorbency incontinence pads also can help. And we can also try some medications, either anticholinergic, if that was urge, or duloxetine if it was stress. And also medication, also although can take some time, but by the time that you will have your wedding, you can find some benefit. Okay, those are if someone tells you, doctor, I need a quick fix. Then recurrent vaginal thrush. So we start now the recurrent thrush, UTI cases, and so on. So it's very good. So recurrent vaginal thrush. If you remember in men's chapter, we mentioned about recurrent balanites. Treat it the same. You need to ask how many episodes. You need to ask about discharge, color of discharge, smell of the discharge. You need to ask about UTI and STI symptoms. You need to ask about sexual history in more details. Partner, does he have any symptoms or not? You need to ask about, because this is lady case or woman health case, contraception, sexual history. Okay, and if she's using any vaginal products from down below, any new chemicals, any creams, any shower gels, and so on. What else? Any recurrent vaginal thrush or any recurrent fungal infection, you need to rule out immunocompromised, like HIV or diabetes or prolonged courses of steroids or a recent broad-spectrum antibiotic. Okay, so it is important to ask these questions. Very important. Okay, plus social history. All right. So again, how to approach? Please be aware that if in the history or if in the doctor's note, your patient is taking fluoxetine medication, dapagliflozin, empagliflozin, be aware that it can induce or it can be a risk factor for recurrent genitourinary infection. That's why it might be one of the causes or one of the possibilities. All right. So in this case, so vaginal thrush is caused by overgrowth of candida or fungal infection or yeast infection, often triggered by factors like antibiotics, hormonal changes, lifestyle factors. It is very common, but recurrent episodes may require further investigations to identify if there is any underlying cause. What we can do, usually diabetes, HIV test, to make sure there is no anything can explain why she's having a recurrent infection. So usually, again, treatment or management, address eyes, diagnosis, face-to-face examination if you think it is needed, like examine hair from down below, take swabs if it is recurrent, so we need vaginal swab to confirm, blood test to rule out diabetes, HIV, liver and kidney problem, medication review. For example, if she's on frozen drug, we can suspend it for some time and see if that will improve her symptoms. Leaflet and safety net. What patient can do? So wear loose cotton underwear. Avoid tight clothes and synthetic fabrics. Maintain a good hygiene around this area. Okay, reduce sugar and diet. Avoid prolonged use of tampons during your period. Avoid prolonged use of tampons. And consider using condoms during sex to prevent reinfection. And safe sex advice. Keep yourself up to date with the smears. All of these are self-help measures. What we can do? Face-to-face, vaginal swabs. Medication review, as we mentioned about if on long or prolonged antibiotic or on broad-spectrum antibiotic, fluoxetine drug, we can suspend and see. Give fluconazole. And we'll come to the fluconazole, how you can give fluconazole. But please don't forget, fluconazole is not for pregnant lady. Very important in any recurrent thrush as well to rule out pregnancy. Pregnancy can be a risk factor for thrush. Any chance you are pregnant, especially if she's in that childbearing age. But fluconazole is not for pregnant lady. Very important. So arrange bloods to rule out other causes, as we mentioned, like diabetes, STI screen, if any risk factor like unprotected sex, multiple partners, and so on. And follow up after a few weeks, and safety net, if any, first of all, safety net, if any new symptoms, severe symptoms, new symptoms happen, or side effect from the fluconazole, any jaundice, persistent vomiting, stomach pain under your right ribs, where your liver is. All right. So is the thrush is STI? No. Vaginal thrush is not STI. And you can see recurrent vaginal thrush in non-sexually active ladies. It is due to candida overgrowth, because patient can ask you, doctor, is it STI? It is not STI. Recurrent thrush, we say it is recurrent thrush if it happens 4 or more episodes per year. 4 or more times each year or per year, it is recurrent thrush. As I told you, if someone coming with recurrent thrush, swabs, send it to the lab to confirm, and then treatment. We give fluconazole 150 milligram every 3 days for 3 doses. And then she will have 1 dose once weekly for 6 months. Every week, she will have 1 dose every 6 months. This is the treatment for recurrent thrush. But if she's pregnant, we don't give oral, give topical until or treat the acute infection until she gives birth, and then we can give oral. Okay, very important. Side effects can cause some liver dysfunction. That's why it's important to safety net against that. Okay, also some rash or some headache, abdominal discomfort, and feeling sick. That is for recurrent thrush. All right.